How many of you have encountered chronic regurgitation in brachycephalic dogs with inconclusive pre-operative diagnostics? Regurgitation is often identified in brachycephalic dogs, and the true pathogenesis and cause is unknown. A diagnostic approach to try and identify a sliding hiatal hernia is often pursued with inconclusive results, and there is a proposed theory that their degree of upper airway compromise predisposes them to regurgitation due to an increase in the transdiaphragmatic pressure gradient, but this has not been proven. So what do we know in terms of what stops regurgitation or reflux? With reflux defined as gastric contents moving into the esophagus, and regurgitation defined as reflux material reaching the oropharynx. The main components that stops reflux includes the gastroesophageal junction and the esophageal hiatus. The esophageal hiatus is surrounded by the left and the right pars lumbalis. Contraction of the diaphragmatic crura at the esophageal hiatus has a pinchcock effect, and it has been shown to substantially contribute to the intraluminal pressure at the gastroesophageal junction. Recent published works by Us and Conte identified that brachycephalics has an enlarged esophageal hiatus, and this likely plays more of a role in the regurgitation noted, and not just a hernia or the proposed impact of upper airway disease. The purpose of this study was to objectively quantify reflux and regurgitation in brachycephalic dogs using a catheter-based pH monitor, and to examine these findings in light of clinical observations. 44 brachycephalic dogs that had a history of regurgitation or presented for upper airway assessment were included. Pre-operatively, owners were asked to fill in a questionnaire to grade the severity of respiratory and gastrointestinal signs, as described by Ponset. An esophageal pH monitor was then placed for 24 hours. This device, called a digitrapper, has two pH sensors spaced 15 centimeters apart. The catheter was placed under total intravenous anesthesia, and the dogs were intubated to secure their airways. 3-view thoracic radiographs were obtained and the catheter placement assessed. The distal sensor was positioned at the level of the 8th rib, and here we see the two sensors distally and proximally. Reflux was defined as an event at the distal sensor, and regurgitation was defined as an event at the proximal sensor. The sedation was then reversed and dogs recovered. Following recovery, recording was started and dogs followed a normal hospital routine, receiving no medications. The following day, they received an upper airway exam and endoscopy. Therapeutic intervention was performed based on the results of our findings. Reflux or regurgitation was classified as when the pH dropped below 4. This is a typical pH trace from a 24-hour study, with the line depicting a pH below 4. Parameters calculated by the software from the data proximally and distally included the percentage time the pH was below 4, the total number of refluxes calculated as reflux per hour, and the duration of the longest reflux in minutes. Respiratory signs were graded based on owner assessment, with 26 out of 44 dogs graded as grade 3. Similarly, gastrointestinal signs were graded, with 13 out of 44 identified as grade 3. The proximal pH sensor identified a mean percentage time in regurg of 6% and a mean of 3.6 regurgitation events per hour, with a mean longest regurgitation of 12.3 minutes. These proximal regurgitation events is an indication of the volume of gastric contents coming up. Reference values has been published for the distal sensor in a purpose-bred large breed research colony consisting of 18 dogs by McMahon. This has not been reported for the proximal sensor. The distal pH sensor identified a mean percentage time in reflux of 9.7%, which is substantially higher than the reported reference of 0.43%, and a mean of 5.4 reflux events per hour, again much higher than the reported reference value of 0.28, with a shocking mean longest reflux time of 26.2 minutes. In people, it has been identified that the percentage time pH is below 4 and the clearance rate of the reflux is what causes typical clinical signs of heartburn and indigestion. Thoracic radiographs did not identify any pulmonary pathology, with a mean tracheal diameter of 16%. 5 dogs had previous airway surgery, but gastrointestinal signs persisted. Laryngeal collapse were included as an indication of their airway resistance, with 15 dogs classified as grade 3. Esophagoscopy was performed in the first 10 dogs enrolled. This was discontinued as it did not provide helpful additional diagnostic information. Surprisingly, given the severity of the reflux identified, only 2 dogs displayed severe mucosal changes. 8 dogs had an open gastroesophageal junction. We also utilized the scope to assess the location of the distal pH sensor, which was consistently located 5 cm proximal to the gastroesophageal junction. Gastroscopy revealed mild or no changes in these 10 dogs. Esophageal and gastric biopsies obtained endoscopically revealed minimal changes. 39 out of 44 dogs underwent upper airway surgery, as 5 had already had previous airway surgery. And 30 out of 44 dogs underwent Chylothomy for a circumferential esophageal hiatal rim reconstruction. All dogs where surgery was pursued displayed a lax phrenicoesophageal ligament and an enlarged esophageal hiatus. For statistical analysis, a standardized reflux score was created using the reference values published by McMahon in 2001. To calculate each parameter score, the measured value was used minus the reference mean divided by the reference standard deviation. As an example, if we measured a total percentage time pH was below 4 of 12%, this resulted in a score of 13.6. A score of 0 indicated perfect agreement with the reference population, and a score of 13.6 indicated the value is 13.6 standard deviations away from the reference mean. With this parameter score, 95% of the population should fall within 2 standard deviations of the mean of the reference population. Thus, a score of more than 2 for each parameter was considered abnormal, and a score of more than 6 for the 3 combined parameters assessed was considered abnormal. The cohort had a mean distal combined score of 40.3, with only 3 dogs identified with a score below 6. Exploration of any relationship of the explanatory variables with the reflux score was examined using simple ANOVA. The combined score number was not explained by the respiratory or the gastrointestinal grade, the laryngeal collapse grade, or whether dogs underwent previous airway surgery. Long-term follow-up was available for 7 dogs that underwent esophageal hiatal rim reconstruction, with a mean distal combined score of -0.9, and no regurgitation events were recorded at the proximal sensor, indicating that circumferential esophageal hiatal rim reconstruction is a promising solution to combat reflux. These dogs did not require any ongoing medication. In conclusion, we report an alarming high number of distal reflux events per hour of 5.4, which is substantially higher than the reference values reported. Of more concern is the percentage time the pH is below 4, with 9.7% reported. We also report an alarming high number of regurgitation events at the proximal sensor, which sits at the thoracic inlet. The high volume of reflux predisposes dogs to aspiration and pneumonia. In people, a high distal percentage time in reflux and a high number of regurgitation events proximally is associated with clinical signs such as heartburn and indigestion. In people, esophageal pH monitoring is considered the gold standard for diagnosing symptomatic reflux and regurgitation. The amount of reflux identified was not explained by any of the clinical variables explored, with only 3 out of 44 dogs considered unaffected. Owner observation did not recognize the severity of the problem, and their degree of respiratory compromise was not associated with the degree of reflux, bringing into question any role the theorized increase in transdiaphragmatic pressure might play. Esophageal pH measurement is a minimally invasive, useful clinical tool to objectively assess their degree of reflux and guide decision-making. I look forward to hearing your comments and welcome any questions.
Laryngeal paralysis is a condition where the muscles that control the movement of the arytenoid cartilages lose their innervation. And so that loss of innervation then leads to lack of abduction of the arytenoid cartilages and an increase in laryngeal airway resistance, because those arytenoid cartilages are then blocking the rhinoglottis. This can be a congenital or a acquired disease, with the acquired form being much more common. The acquired form is commonly associated with an idiopathic geriatric onset polyneuropathy, which commonly affects older large breed dogs like Labradors and St. Bernards. Clinical signs for this disease can vary from mild to severe, with mild clinical signs being change in phonation, coughing while eating or drinking, and exercise intolerance. On the more severe end of things, patients that are bilaterally affected can present on an emergent basis for upper airway obstruction. And so diagnosis of laryngeal paralysis is achieved through a sedated upper airway exam, where we can evaluate the movement of the arytenoid cartilages. But in general, surgical management is always recommended for treatment of these patients, because they're always going to be at risk for developing an acute upper airway obstruction if they aren't treated. And so goals of surgical intervention are going to be to decrease laryngeal airway resistance. And we do that by increasing the rhinoglottis area. But we don't want to increase the rhinoglottis area so much that we're going to increase the risk for aspiration pneumonia. And so reported surgical procedures for treatment of laryngeal paralysis include both unilateral and bilateral arytenoid lateralizations, ventriculocordectomy, partial arytenoidectomy, and castellated laryngeal fissure. The gold standard procedure, though, is definitely going to be our unilateral arytenoid lateralization. This is the gold standard because it's associated with a relatively low morbidity and mortality rate and pretty good outcomes. And so one study looking at patients who underwent a unilateral arytenoid lateralization for treatment of their laryngeal paralysis found that 90% of owners saw an improvement in clinical signs of their pet following surgery. But there still is an overall complication rate reported to be between 10 and 28% following this procedure, with the most common complication being aspiration pneumonia, which is reported, depending on which paper you read, between 5 to 24% of cases. Other potential complications of this surgery include recurrent airway obstruction from suture failure and persistent long-term coughing. But focusing mostly on aspiration pneumonia, we think that lack of coverage of the rhinoglottis is basically what contributes to that increased risk for aspiration pneumonia following surgery. And so if you think about how the unilateral arytenoid lateralization is performed, it very asymmetrically lateralizes one of the arytenoid cartilages. And it's thought that this asymmetry basically disrupts the epiglottic seal that should be there to decrease the risk of aspiration pneumonia. And so it was our thought that we could come up with a retractor that maybe more evenly abducts the arytenoid cartilages, enough so to decrease the laryngeal airway resistance, but also, not enough to disturb the epiglottic seal, and therefore have a procedure that may actually prevent aspiration pneumonia. And so the purpose of our study was to evaluate the effects of said arytenoid retractor on the resistance of canine larynges with both the epiglottis open and closed. Our primary hypothesis was that the retractor would lower laryngeal airway resistance compared to baseline with the epiglottis open, and that there would be no significant difference in laryngeal airway resistance after placement of the retractor with the epiglottis closed. And so we obtained 6 canine larynges from the cadavers of large breed dogs that we obtained from a local shelter. We confirmed that all 6 dogs were strays and that they were euthanized for reasons unrelated to their upper airway disease. To prepare our specimens, all the extrinsic soft tissue structures were removed from each specimen, leaving only the laryngeal cartilages, the hyoid, the intrinsic musculature, and 5 tracheal rings. I worked with the biomedical engineering department over at RIT to help me with the design for our retractor. And so we used some 3D reconstructed images of a larynx from an unaffected Labrador who was anesthetized. We had CT images of this Labrador when there was an appropriately sized endotracheal tube in place. And we used those images to help figure out the shape of our retractor. And once we had our shape, we could come up with a few different sizes. So we scaled that example up and down so that we would have a couple different sizes ranging in rim glottis width from 6 to 16 millimeters. So we could use the retractor in multiple different size larynges during testing. And so our 6 models were then printed in polylactic acid and used for testing. So you can see from this image here that our retractor is placed across the corniculate processes of both the arytenoid cartilages and secured with 2 sutures through the 2 holes that you can see there. This allows for a more even bilateral abduction of the arytenoid cartilages. The size of the retractor that we used for each specimen corresponded with both the width of the epiglottis. So we wanted to make sure that we didn't increase the rim glottis beyond the width of the epiglottis in fear of losing the epiglottic-glottic seal, and that we also wanted to increase the rim glottis by at least 1.4 to 2 times the size of the untreated larynx, so we could make sure we were actually going to reduce laryngeal airway resistance. We then placed a stay suture at the tip of the epiglottis to help us open and close the epiglottis during testing. As you can see here, this is our setup for testing. We have a larynx in a PVC chamber. It has an airtight seal around the tracheal rings at the end there, so that the larynx and the trachea are open to the atmosphere, but no air can leak out around that. On the opposite end, you can see a high flow air circuit and a digital manometer. The manometer was used to measure our airway pressure during testing. And so we completed all testing on the untreated larynx first with the epiglottis open and then closed. We removed the larynx from the PVC chamber, placed our retractor, put it back in the chamber, and again tested with the epiglottis open and closed. With the epiglottis open, we tested at a range of airflows from 15 to 60 liters per minute. We increased at increments of 15 liters per minute during that testing. When the epiglottis was closed, we only tested at 1 airflow of 10 liters per minute. During each testing, we recorded 3 pressure measurements for each flow rate in centimeters of water, and then used that information to calculate laryngeal airway resistance using the formula that you can see on the slide there, where delta P is equal to the pressure gradient across the larynx and V is equal to airflow. And so in our study, each larynx functioned as its own control. And so comparisons of resistance pre and post retractor placement at each flow rate were evaluated by means of the Wilcoxon signed rank test. All of our data were reported in median resistance with 25th and 75th quartiles, and significance was set at 0.05. In our study, we found that there was a significant reduction in laryngeal airway resistance with the retractor in place and the epiglottis open for flow rates between 15 to 45 liters per minute. Unfortunately, there was a lack of significance at the 60 liter per minute time point when all 6 larynges were evaluated. With the epiglottis closed, we found no significant difference in the median laryngeal airway resistance between the baseline and the treated larynges. And then I just put these images in here so you guys could subjectively appreciate the difference in rim glottis width between the untreated larynx on the left and the treated larynx on the right. And so we accepted our primary hypothesis that the retractor would decrease laryngeal air resistance when the epiglottis was open. Failure to reach significance at the highest flow rate was due to collapse of one of the larynx. The smallest larynx that we tested collapsed at that high flow rate, and so we were not able to get all of our values at that high flow rate. We did, however, find that if we removed that larynx from testing, that other 5 that made it through that 60 liter per minute testing did have a significant decrease in resistance with the retractor in place. We also accepted our secondary hypothesis that there would be no significant difference in airway resistance pre and post placement of the retractor with the epiglottis closed. And so this indicates to us that with the retractor in place, that we can maintain the epiglottic-glottic seal, which may then help to prevent aspiration pneumonia. And another benefit that I did not evaluate in the study, but that I wanted to mention, was that we hopefully will be placing this retractor per os, which will eliminate the need for postoperative opioid analgesia, which has been reported to be a risk for aspiration pneumonia as well. And so limitations of our study were definitely loss of that larynx and significance at the 16 liter per minute time point of all 6 larynges. This was a pilot study, so we didn't evaluate at all what material we would actually be using to build this retractor in real life. Also, we did use canine cadaveric larynges, so we don't know how well this is actually going to be tolerated in dogs in real life. We concluded, though, that the bilateral arytenoid retractor may reduce clinical signs of laryngeal paralysis and offer protection against aspiration pneumonia based on our results. However, further testing is definitely needed to determine the optimal material and to probably compare it to the gold standard procedure. These are my references. And I just want to thank everyone at Veterinary Specialists and Emergency Services and the Biomedical Engineering Department at RIT for all of their help, as well as everyone at the Veterinary Soft Tissue Society for allowing me to present this research today. I will now open the floor for questions.
Historically, tube tracheotomies have been the only feasible method to bypass upper airway obstructions. There has been little innovation in this method, but there are 2 studies of interest. Perhaps the most compelling is the silicone stent tracheotomy, which uses a rubber tunnel to maintain a stoma. Bird also published on a Penrose drain sling to improve tracheotomy tube management. Unfortunately, these 2 techniques still involve placing a foreign object into the body, which incites excessive mucus production and can contribute to a high complication rate. In addition, tube tracheotomies are labor-intensive to manage in hospital. Inappropriate or inadequate management leads to complications, including life-threatening mucus plug obstruction and tube dislodgement. In the literature exploring tube tracheotomies, the overall complication rate in dogs can be as high as 95%. One study focused solely on cats found an overall complication rate of 87%. Today, I would like to introduce a novel temporary tracheotomy technique which forgoes the tube. I will describe the technique as well as the type and incidence of complications. Our null hypothesis is that this novel tubeless tracheotomy technique does not have a higher complication rate than the traditional tube tracheotomies. This was a retrospective study involving cases since January 2016. While this technique has been performed at our facility for the past 10 years, due to record losses, only cases from 2016 to 2021 were included. This study included 33 animals total, the majority being dogs. Information collected from the medical records includes signalment, indication for the tracheotomy, time to discharge, complications, and patient outcome. So first, let us go over this procedure in detail and highlight its differences from other tracheotomy techniques. The patient is placed in dorsal recumbency with a rolled towel under the neck. The rolled towel promotes ventroflexion and moves the trachea into a more superficial position. Field preparation is routine, clipping from the ramus of the mandible to the thoracic inlet. A ventral midline incision should be made, caudal to the cricoid cartilage and centered over the proximal third of the neck. In general, the length of the incision is usually about 1/4 of the neck length. Bluntly dissect the subcutaneous tissue down to the sternohyoid muscles, and then these muscles can be separated at their median raphe to expose the trachea. To mobilize the trachea and improve exposure, bluntly dissect the dorsal fascial attachments. The sternohyoideus muscle can be elevated to access the lateral aspects of the trachea. A curved instrument can be used underneath the trachea to retract other tissues and create an ideal tracheotomy field. The level at which to perform the tracheotomy varies with the breed. In non-brachycephalic breeds, the tracheotomy should be made between tracheal rings 4 and 5. In brachycephalic breeds, Due to their shorter necks, it is better to make the tracheotomy more cranial, between rings 2 and 3 or 3 and 4. The tracheotomy incision should include about 40 to 50% of the tracheal circumference, not to exceed 50%. After the tracheotomy incision is made, you can remove this instrument. The difference between this technique and a permanent tracheostomy is what tissues the sutures engage and the use of absorbable suture. For closure, small gauge, rapidly absorbable suture should be used. At our facility, we commonly use 4/0 to 5/0 monochrome. An interrupted pattern will be used to close the tracheotomy. The first 2 sutures are the most important and should be placed at the commissures of the tracheal incision. The suture will engage the dermis and the subcutis, the medial edge of the sternohyoideus, and full thickness through the trachea. Skin should not be engaged when closing the tracheotomy, as this is more likely to lead to stoma persistence. The next few slides will demonstrate this crucial initial suture placement. Here, the first bite engages the dermis and subcutis, then engages the medial edge of the sternohyoideus, and from the sternohyoideus, the suture should engage full thickness through the trachea at the commissure of the tracheotomy. Here is the trachea with both initial simple interrupted sutures at both commissures. As you can see, this adequately elevates the trachea, as well as excludes the sternohyoideus muscle from the field. From here, additional simple interrupted sutures are placed, engaging both the trachea and the dermis. These sutures should be placed moving lateral to medial. Once the skin is opposed at the cranial and caudal edges of the tracheotomy, the skin can be closed primarily. This slide illustrates after placing those first 2 sutures, you continue to add simple interrupted sutures on either side, engaging full thickness trachea to subcutis and dermis. And after closing the skin, here is the finished product. Managing these cases postoperatively involves attention to respiratory character and attention to the stoma. At our facility, respiratory watch indicates hourly respiratory rates and effort evaluation. Supplemental oxygen is not expressly needed, but can be used if indicated. The stoma should be examined every 2 hours and cleaned as needed. Baby wipes can be used to clean the surrounding skin of excess mucus, and skin emollient like Aquaphor can be used to prevent skin irritation. Suctioning is typically not needed, as mucus obstruction is much less likely, but it is sometimes indicated in the case of productive disease. If necessary, a cotton-tipped applicator moistened with sterile saline can be used to clear any mucus away at the tracheotomy. Moving on to the results of this retrospective study, here are the population demographics of the 29 dogs. A majority of the dogs are brachycephalic breeds. 55% of the dogs were male castrated, and 34% were female spayed. Weight ranged from 5.5 to 44 kilograms, and age ranged from 3 to 13 years. Here are the population demographics for the cats. None of the cats were a brachycephalic breed, and all of the cats were male castrated. Weight ranged from 4 to 6 kilograms, and age ranged from 11 months to 18 years. These statistics are for the entire 33 patient population. The majority of cases required airway diversion secondary to brachycephalic obstructive airway syndrome. Only 15% of patients had it performed secondary to laryngeal paralysis. Among cats specifically, 3 out of 4 cats had tracheotomies performed preemptively in conjunction with biopsies of partially obstructive laryngeal masses. The majority of tracheotomies are performed under emergent conditions. About 40% of cases had tracheotomies performed preemptively in conjunction with other airway procedures. In this case, a common situation would be surgeon observation of the severity of airway disease and evaluating the risk of post-surgical inflammation either preoperatively or intraoperatively. Overall survival rate 2 weeks post-tracheotomy was 73%. 21% of patients were euthanized in the postoperative period due to underlying disease. 1 cat was euthanized for reasons directly attributable to the tracheotomy. There was 1 case of a dog representing after discharge in respiratory distress and later dying in the hospital. Complications noted in the medical records were recorded and quantified. Mild, manageable mucoid discharge is not included as a complication, as it is an expected side effect of a tracheotomy. Approximately 45% of dogs experienced at least 1 minor complication, and 14% of dogs experienced at least 1 major complication. Stoma persistence occurred in 28% of patients. It is a complication that sometimes necessitates a second procedure to close the stoma. Of these 8 patients, 5 patients returned for surgical closure of the stoma. Neck fold obstruction is considered a minor complication as it can be quickly addressed by placing stay sutures in the surrounding skin and looping umbilical tape over the dorsal neck to pull the folds away from the tracheotomy. As for severe complications, 2 dogs were diagnosed with clinical pneumonia post-tracheotomy, and 2 dogs, as their tracheotomies were healing, failed airway normalization and required conversion to a permanent tracheostomy. Among cats, 2 of the 4 cats experienced all of the complications listed here. 1 cat experienced copious mucus production, which resulted in frequent mucus plug obstruction and respiratory distress in the hospital. The patient was later discharged, but returned less than 24 hours later due to concerns for recurrent mucus plug obstruction. This cat represents the one case of a patient who was euthanized due to direct complications of the tracheotomy. 1 cat had dehiscence of the tracheotomy site 48 hours after the procedure and required a revision procedure. Airway sampling at this time diagnosed bacterial tracheitis, which may have contributed to this dehiscence. Evaluating the complication rate of this technique must be considered in light of the patient population. Tracheotomy is a salvage procedure and is sometimes unsuccessful in these severe cases. For example, 3 canine patients returned for rehospitalization due to persistent respiratory difficulty. On intake examination, the tracheotomy was found to be intact and patent in all 3 cases. The majority of patients can be discharged relatively quickly after the procedure. The average time to discharge after tracheotomy is approximately 3.5 days. These patients can go home with a functional alternative airway that we expect to slowly close within 6 to 8 weeks. This allows for gradual conversion to a normal airway. Skin fold obstruction is a relatively unique complication of this technique. This complication primarily affected brachycephalic breeds. In most patients, this is identified at the time of tracheotomy, but it can also be rectified in the awake patient. Although our data on cats is limited, these 4 cases imply that cats are prone to major complications with a tubeless tracheotomy, just as they are with a tubed tracheotomy. While mucus plug obstruction is a major and frequent concern with tubed tracheotomies, only 1 feline patient of the entire patient population experienced this complication, suggesting that copious mucus production resulting in respiratory distress is much less common with a tubeless tracheotomy. Our overall complication rate was 52%, as compared to the over 85% overall complication rate for tubed tracheotomies. Thus, our null hypothesis was accepted. The complication rate for the tubeless tracheotomy technique is not higher than the reported complication rates of traditional tube techniques. Limitations of this study include the retrospective nature and the lack of a comparison group. Many cases were lost to follow-up as it was only pursued if complications occurred. It would have been very valuable to directly compare the complications outcomes of tubed versus tubeless tracheotomies, but we have not performed a tube tracheotomy for non-anesthetic purposes in nearly 8 years. With the ease of in-hospital management and perceived better outcomes, the surgeons, criticalists, and nurses of our facility prefer it over the tubed version. Additionally, very few cats had this procedure performed during the study period, which makes it difficult to draw significant conclusions about this population. Thank you for your time. Are there any questions that I can answer?
Chylothorax is the accumulation of visceral lymph within the thorax, and it is associated with considerable morbidity and mortality. A recent systematic review of the veterinary literature concluded that treatment of idiopathic chylothorax supports surgical intervention. Surgical treatment employs a combination of thoracic duct ligation, pericardectomy, or cisterna chyla ablation as standard of care. However, long-term success is variable and ranges between 50 to 85%. The pathogenesis behind failure and/or recurrence suggests that missed thoracic ducts or formation of new ducts may explain cases with unsatisfactory outcomes. Recently, evidence of invisible or sleeping ducts that are collapsed and not visible in preoperative CT lymphangiograms were documented by Kenai et al. In a cohort of dogs with idiopathic chylothorax. Chylothorax. Thoracic duct embolization is standard of care in humans. It is minimally invasive and has consistently high success rates. Recently, a study by Nadolsky et al. Documented the successful outcome in 49 out of 50 patients undergoing thoracic duct embolization following failed thoracic duct ligation. Veterinary knowledge and literature on lymphatic embolization is scarce. The experimental report by Pardo described an open approach to lymphatic catheterization and embolization, and Singh et al. Described a percutaneous approach, which was deemed technically challenging and not clinically recommended. Clinical reports are limited to a small case series of 2 dogs undergoing lymphatic embolization as a salvage procedure following failed primary therapy. The rationale behind lymphatic embolization is simple. It has the capacity to prevent or reduce chyle flow into the chest. It prevents flow into potentially missed or silent thoracic duct branches, and it may prevent collateralization or formation of new branches that may bypass the ligation site. The objectives for the study were first to describe the embolization technique and clinical outcome of lymphatic embolization in dogs with chylothorax, and second, to describe the characteristics of the radiopaque embolus using CTLA 12 weeks following surgery. We hypothesized the lymphatic embolization would be technically feasible and clinically effective in treatment of dogs with idiopathic chylothorax, and that postoperative CT would demonstrate the presence of a robust embolus, lack of cranial flow of radiocontrast past the embolus site, and presence of the silent or sleeping thoracic duct branches. A prospective trial with Iacuk in hospital approval was advertised for dogs diagnosed with idiopathic chylothorax. Admission into the study required a preoperative CTLA, echocardiogram, and complete database. Patients underwent standard care surgery, thoracic duct ligation, pericardectomy, with the addition of lymphatic embolization. A recheck CTLA was scheduled for 12 weeks following surgery, and long-term outcome was documented via recheck evaluation or phone communication. Surgical approach was planned as previously described by Allman in 2010 for VATS thoracic duct ligation and pericardectomy. Embolization was performed via mini-laparotomy under fluoroscopic guidance. For embolic solution, a 3-to-1 mixture of Lipiodol and N-butylcyanocrylate glue was chosen and administered via catheterized efferent abdominal lymphatic at a starting volume of 0.1 mL per kg delivered under fluoroscopic guidance. CTLA studies were reviewed by a board-certified radiologist. Additionally, volume render models were obtained and used to help characterize our findings. The CT and 3D models were evaluated for the presence of an embolus, lack of contrast flow past the embolus, and presence of silent or sleeping branches. A total of 8 dogs were included in the study. The median age was 52 months of age, and a median body weight was 21.4 kilograms. Dog 1 was approached in sternal recumbency. VATS thoracic duct ligation, pericardectomy, and embolization were performed successfully. There was a decrease in pleural effusion, volume, and chylous character. However, a biopsy of a ventral swollen thoracic region revealed a diagnosis of lymphangiosarcoma, and the dog was euthanized 14 days following surgery. Therefore, no CTLA is available. Dog 2 was approached in sternal recumbency. VATS thoracic duct ligation and pericardectomy were performed successfully. However, the inability to catheterize lymphatic vessels led to an attempt to perform the embolization via intranodal injection, which was unsuccessful. There was resolution of pleural effusion, and the dog is alive and normal 800 days following surgery. There is no CTLA for this dog. Dogs 3 and 4 were approached in sternal recumbency. VATS thoracic duct ligation, pericardectomy, and lymphatic embolization were performed successfully. Both dogs showed resolution of clinical signs and pleural effusion. Both are clinically normal at 620 days and 450 days following surgery, respectively. Both underwent CTLA 12 weeks after surgery. Dog 5 was approached in dorsal recumbency due to the formation of iatrogenic pneumothorax following thoracocentesis the night before surgery. Require a combined ciliotomy and caudal sternotomy for thoracic explore. Caudal left lung lobectomy, pericardectomy, and lymphatic embolization were performed in dorsal recumbency. Thoracic duct ligation was not performed in this case. The dog showed resolution of clinical signs and pleural effusion, and is clinically normal 180 days following surgery. CTLA was performed 12 weeks following surgery. Dog 6 was approached in sternal recumbency. VATS thoracic duct ligation, pericardectomy, and lymphatic embolization were successful. Dog showed resolution of clinical signs, pleural effusion, and is clinically normal 130 days following surgery. CT was performed 12 weeks following surgery. Dog 7 was approached in dorsal recumbency due to a suspicion of a bulla or bleb lesion in the caudal left hemithorax on CTLA review the day of surgery. A VATS thoracic explore was performed, finding no evidence of pulmonary pathology. A VATS pericardectomy and lymphatic embolization were performed in dorsal recumbency. Thoracic duct ligation was not performed. The dog showed resolution of clinical signs and pleural effusion and is clinically normal 100 days following surgery. CTLA was performed at 12 weeks. Dog 8 was approached in sternal recumbency for VATS thoracic duct ligation and pericardectomy. However, the inability to catheterize lymphatic vessels led to the abandonment of the embolization procedure. There was resolution of pleural effusion and clinical signs, and the dog is clinically normal and alive 90 days following surgery. Follow-up CT was obtained 10 weeks following surgery. The presence of a lymphatic embolization was documented in all dogs that underwent successful embolization, with all cases showing embolus reaching the efferent lymphatics and cisterna chyli. Dog 5 and 7 showed the presence of an embolus into the thoracic duct and cranial mediastinum. Lymphangiogram was obstructed in every case with no evidence of contrast flow cranial to the embolus site. Lastly, Dog 7 revealed the presence of a silent thoracic duct branch, which was undocumented in preoperative CT, which had filled with embolus. Lymphatic embolization is a feasible addition to primary therapy for dogs with idiopathic chylothorax. Access to the abdominal lymphatics was successful from both sternal and dorsal recumbency. Thoracic duct ligation was not pursued in dorsal recumbency due to the poor visibility and access to the duct. However, in both cases where this was performed, the presence of a robust embolus reached and filled the thoracic duct, arguably negating the need for ligation. 2 embolization failures were encountered in this trial. Both dogs were under 10 kilograms and were the smallest patients in the study. Their size made lymphangiography and subsequent catheterization of the abdominal lymphatics very challenging and unsuccessful. Based on these results, we do not recommend lymphatic embolization using this approach, and alternative approaches to embolize small dogs should be investigated. Lymphatic embolization appears to be clinically efficacious as an addition to primary therapy in dogs with idiopathic chylothorax. The main question that remains unanswered is the possibility that all dogs in this trial could have had the same clinical outcome without lymphatic embolization. Alternatively, the possibility that some of these dogs may have failed or had recurrence without lymphatic embolization is also unknown. Again, a prospective controlled trial is needed to validate the use of embolization without thoracic duct ligation as sole method of lymphatic obstruction in dogs with idiopathic chylothorax. Review of CTLA 12 weeks following surgery reveals the presence of a robust lymphatic embolus in all cases where embolization was performed. In figure A through C, pre-lymphangiogram cross-sectional slices moving caudal to cranial reveal the presence of a robust cisterna chyli embolus. Figures D through F demonstrate the cross-sectional images at the same location as above after lymphangiography and show the decrease and eventual absence of any radiocontrast flow past the embolus. Using DICOM images to make 3D models helps illustrate the lack of radiocontrast to the embolus. As you can see in the top model of dog 6, the thoracic duct clips are outlined with a red arrow, and the embolus is outlined in green. In the bottom figure, the lack of cranial flow of contrast, which is outlined in blue, can be seen in the mid-abdomen far beyond and behind the site of ligation. This model of dog 7 shows similar findings in a case where thoracic duct ligation was not performed. As you can see, the lymphangiogram does not reach the thorax and does not advance past the caudal aspect of the embolus. In contrast, the model from dog 8, in which lymphatic embolization was abandoned due to technical difficulties, shows the flow of radiocontrast into the thorax, right up to the site of thoracic duct ligation. One can speculate that if a collateral, a silent, or a missed branch were to recanalize, chyle flow would likely circumvent the ligation site. Interestingly, the postoperative CTLA of dog 5 shows a previously undocumented silent branch, that was captured and obstructed by the lymphatic embolus. Although beyond the scope of the study, one can speculate that thoracic duct ligation of this single branch may have led to a surgical failure. The embolus allowed for the occlusion of the sleeping branch without prior knowledge of its existence. This may provide proof of concept that lymphatic embolus may be superior to thoracic duct ligation by allowing occlusion of missed or silent thoracic duct branches. The limitations of their study is the small number of clinical patients, which makes statistical data analysis impossible, and the variable number of surgical approaches and concurrent adjunctive therapy that do not allow for comparison of embolization to primary modes of therapy. In conclusion, the addition of lymphatic embolization is feasible as primary therapy in dogs with idiopathic chylothorax. A robust embolus was documented in all dogs with follow-up CTLA, and the prevention of flow of radiocontrast past the embolus site was documented in all cases with successful embolization. Lymphatic embolization may lead to improved clinical outcome by reducing the efferent lymphatic flow of chyle near the chest, occluding flow of missed thoracic duct branches, and the prevention and development of new branches. The main question that remains is whether thoracic duct embolization or lymphatic embolization can be performed as the primary treatment. Additionally, alternative approaches to embolization are possible, as seen here by this VATS-assisted cisterna chyli embolization. I want to take this time to thank Dr. Brad Case for his mentorship throughout this process as a student, an intern, now a resident, and the rest of my co-authors for their support and experience, and to all of you for tuning in.
Primary pulmonary neoplasia is an uncommon but important cause of pulmonary pathology, representing approximately 1% of newly diagnosed canine tumors. The majority of these tumors are malignant and spread local regionally, either throughout the lungs or to draining lymph nodes, though distant metastasis is possible. Benign lesions are rare but include adenomas, papillomas, hemangiomas, and granulomas. Histologic classification of canine lung tumors was last broadly evaluated by Ogilvie and colleagues in 1989, at which time a retrospective analysis of 210 dogs found that 97% of tumors were consistent with carcinoma. Additional tumor types that have since been reported in the veterinary literature include primary pulmonary histiocytic sarcomas, fibrosarcomas, chondrosarcomas, mast cell tumors, and neuroendocrine tumors, suggesting the need for updated information regarding the histopathologic distribution of primary lung tumors in dogs. Surgical resection represents the recommended treatment of primary lung tumors. However, the decision to proceed with surgery is often influenced by expected long-term survival, which may vary by tumor type. Regardless, a median survival time of approximately 1 year is often referenced. This is largely based on previous retrospective studies that solely evaluated the survival of dogs undergoing surgery for pulmonary carcinoma. More contemporary studies evaluating various lung tumors have reported median survival times ranging from 60 to 952 days. In 2020, Lee and colleagues developed the Canine Lung Carcinoma Stage Classification System, or CLCSC, which was adapted from the most recent human staging guidelines. In a retrospective study of 71 dogs undergoing surgical treatment for pulmonary carcinoma, this staging system was highly prognostic for survival. An additional but important finding in this study was the lack of survival benefit in dogs who received adjuvant chemotherapy. While the CLCSC does provide much needed updated prognostic information, its application is limited to dogs with pulmonary carcinoma, and survival between the many neoplasms that make up primary lung tumors in dogs may vary. The primary objective of this study is to provide an updated histopathologic distribution of primary pulmonary neoplasms among a large group of dogs from various institutions and to describe associated outcomes in order to better aid clinicians and owners making preoperative decisions. A second objective was to evaluate the effect of postoperative adjuvant chemotherapy on outcome in dogs with pulmonary carcinoma by clinical stage of disease. We hypothesized that carcinomas would continue to represent the majority of primary pulmonary tumors, but that other tumor types, specifically non-epithelial neoplasms, would be associated with variable survival outcomes when compared to pulmonary carcinoma. We also hypothesized that adjuvant chemotherapy would improve median survival in dogs with pulmonary carcinoma when evaluated by stage. A medical record search was conducted to identify dogs that underwent surgical resection of primary lung tumors at 8 academic institutions between 2010 and 2019. Dogs were included if they received surgery for removal of a primary pulmonary mass and had a histopathologic diagnosis. Dogs were excluded if histopathology reports were suspicious for metastatic neoplasia or when concurrent or historical extrathoracic primary neoplasia was consistent with pulmonary mass histology. Preoperative data recorded from medical records included signalment, clinical signs and exam findings attributable to a pulmonary mass, and history of concurrent or previous neoplasia. Preoperative diagnostic information recorded included the results of fine needle aspirate cytology or biopsy if performed, any hematologic abnormalities, thoracic and abdominal imaging modality and findings, tumor size, the presence of abnormal thoracic lymph nodes on CT, and the presence of pulmonary or distant metastasis. Histopathologic data collected included diagnosis and the presence of metastatic lymph nodes for cases in which lymph node extirpation was performed. Chemotherapy protocols and adverse events were also recorded. An outcome was determined from a combination of medical records, primary veterinarian, and owner communication. Overall survival and tumor-specific survival were estimated using Cox proportional hazards modeling, and survival between carcinoma groups treated with adjuvant chemotherapy and surgery alone was compared for each CLCSC stage using log rank comparisons. 340 cases met inclusion criteria and were included in the statistical analysis with a median follow-up time of 494 days. The average age was 10 years, and mixed breed dogs were the most commonly represented. However, among dogs with histiocytic sarcoma, Bernese mountain dogs and miniature schnauzers accounted for over 50% of cases. Cough was the most common clinical sign and was present in about a third of cases. However, primary lung tumors were identified incidentally in 37% of cases. Most dogs were approached via an intercostal thoracotomy, and minimally invasive techniques or wider open approaches were utilized less commonly. Complete lobectomy was performed in the majority of cases, with partial lobectomy being feasible in 10% of cases, and a combination of partial and complete lobectomy required in 2% of cases. Perioperative mortality was defined as death within 14 days of surgery and occurred at a rate of 5.9%. Acute respiratory distress syndrome, PTE, and persistent pleural effusion resulting in euthanasia were the most common causes of perioperative death. Overall, malignant lesions accounted for 97% of cases. Pulmonary carcinoma was the most frequently encountered neoplasm, accounting for 87% of cases. Sarcomas represented nearly 8% of cases, with histiocytic sarcoma being the most common. Neuroendocrine tumors accounted for 1.5% of cases, and 1 carcinosarcoma and 1 plasmacytoma were also reported. Pulmonary adenoma was the sole benign lesion, accounting for 3.2% of cases. Median overall survival for all dogs with pulmonary neoplasms was 400 days. 1-year survival was 46% and decreased to approximately 21% by 2 years. Survival analysis of malignant neoplasms, for which at least 5 cases were represented, resulted in significantly different survival times between groups, with median survival of the histiocytic sarcoma cohort being 300 days, carcinomas 399 days, and neuroendocrine tumors surviving 498 days. We also investigated the effect of adjuvant chemotherapy for each clinical stage of disease for dogs with pulmonary carcinoma. 227 cases had sufficient information available in the medical record to apply the CLCSC system, and 78 of these dogs completed the intended course of postoperative chemotherapy. Single-agent vinorelbine or carboplatin were the most commonly used protocols. However, treatment plans were highly variable. Overall, chemotherapy did not significantly impact survival for any stage of disease, though the chemotherapy groups often had numerically shorter survival. Though it was not the primary objective of this study, we also evaluated the appearance of intrathoracic lymph nodes on CT and histopathologic evidence of metastasis. Preoperative CT was performed in 327 of 340 cases, of which 28% had evidence of lymphadenopathy and about 72% had normal appearing lymph nodes on their preoperative scans. Given the retrospective nature of this study, lymph node sampling was inconsistent. However, based on the information available, we were able to predict true nodal metastasis to be present in approximately 28 to 44% of cases that had abnormal lymph nodes on CT. Importantly, nearly 1/3 of lymph nodes sampled from dogs with normal appearing lymph nodes on CT had histologic evidence of metastasis. Given the relatively low rate of sampling performed, this may be a conservative estimate of true nodal metastasis in dogs with normal appearing lymph nodes on preoperative imaging. In summary, carcinoma was the most frequently encountered primary pulmonary neoplasm among dogs undergoing surgical treatment for a pulmonary mass, although sarcomas and neuroendocrine tumors comprised almost 10% of cases. This study supports the hypothesis that carcinomas continue to represent the most commonly encountered primary pulmonary neoplasm in dogs. However, non-epithelial tumors occur more frequently than previously reported. Survival was significantly different between carcinoma, histiocytic sarcoma, and neuroendocrine tumors, emphasizing the importance of recognizing the relative incidence of these varying histologic diagnoses. Nodal metastasis was identified in several dogs with normal appearing lymph nodes on CT, and given the prognostic significance of lymph node metastasis on survival, we recommend lymph node extirpation or biopsy in all dogs undergoing surgical treatment for primary lung tumors, regardless of CT appearance. The results of this study do not provide convincing evidence to support or refute the use of adjuvant chemotherapy in dogs with pulmonary carcinoma. Therefore, the therapeutic benefit in this population remains uncertain. Treatment protocols were varied, and dogs with advanced stages of disease were more likely to receive chemotherapy. Therefore, treatment bias and unmeasured variables such as vascular or lymphatic invasion may be affecting these results. Further investigation in the form of prospective randomized clinical trials is needed to determine the effect of adjuvant chemotherapy for treatment of dogs with pulmonary carcinoma. Limitations of this study include the retrospective nature of data collection and the limited sample size used to draw conclusions for some groups, such as the histiocytic sarcoma and neuroendocrine cohorts. Lack of standardized case management may have also influenced our results. For example, preoperative imaging and abdominal staging were variable. Therefore, disparity in sensitivity of detection of metastatic disease may have led to inconsistent staging. As previously mentioned, the lack of standardized chemotherapy protocols and the potential for case selection bias confounds the ability to interpret the impact of adjuvant chemotherapy on survival for pulmonary carcinoma. In conclusion, carcinoma represents the most common primary pulmonary neoplasm in dogs. However, histiocytic sarcoma and other rare tumors reported here should be considered as differentials, as survival between the tumor types is significantly different. The effect of adjuvant chemotherapy for treatment of pulmonary carcinomas remains unknown, and future prospective studies are needed to investigate its impact on survival. I'd like to thank the Society of Veterinary Soft Tissue Surgery for giving me the opportunity to present at this year's meeting, and I'd also like to thank my mentor, Dr. Valerie Scharf, for all of her help and support over the past year, as well as all of the co-authors who made this study possible. And with that, I would be happy to take any questions.
Pericardial effusion is relatively common in our canine population with a prevalence of 0.4%. Typically, we see these dogs as being older dogs with a predilection for male large breed dogs with an overrepresentation of golden retrievers. For this case specifically, we'll be referring to hemorrhagic effusion, the most common causes being idiopathic and neoplastic in nature, but there are other causes of hemorrhagic effusion, including trauma, rodenticide toxicity, and left atrial tear secondary to mitral valve disease. The most dangerous of clinical signs of pericardial effusion is cardiac tamponade and cardiogenic shock, which is defined as the reduction in cardiac output due to increased ventricular diastolic filling pressures, which equates to a poor pulse quality. These guys have an increase in systemic venous pressure, and we can see direct compression of the coronary arteries, leading to decreased cardiac perfusion secondary to this. This diagnosis is typically seen in an emergency situation, most commonly by fast scan. We can see other signs on things such as ECG, where we see electrical alternans, such as the ECG below, and a globoid appearance to the heart on thoracic radiographs. Should patient stability allow for it, echocardiograms can be performed in order to differentiate between idiopathic and neoplastic effusions. These typically show a compression of the right atrium, and in terms of cardiac mass detection, has an 82% sensitivity and 99% specificity for right atrial masses, as well as a 74% sensitivity and 98% specificity for heart-based masses. 45% of these dogs have recurrent effusion and require repeat pericardiocentesis, which means that multiple drainages may be necessary within the same hospitalization stay. It is at this point that we recommend surgical intervention, as interventions have shown to significantly increase the median survival time of dogs with both heart-based masses and idiopathic effusions significantly. Surgical options at this time include pericardectomy and mass resection, typically by median sternotomy, a subtotal pericardectomy, pericardial window with thoracoscopy, and minimally invasive solutions such as percutaneous balloon pericardotomy have been reported. So the motivation for our study was to provide a minimally invasive option for dogs with recurrent pericardial effusion that are not good surgical candidates, or owners are reluctant to pursue more invasive or costly surgical options. Pericardial effusion in humans is currently handled by placing a pericardial catheter for extended drainage, reducing the signs and rates of recurrence of cardiac tamponade, and actually we see a significantly lower rate of mortality associated with this. Rates of complications between those with pericardial catheters and those without were very minimal. This has been performed in our veterinary species as well. A paper out of the Royal Veterinary College showed that extended pericardial catheters in dogs showed no significant difference in a rate of arrhythmias or the length of procedure compared to traditional pericardiocentesis. This was performed with a 14-gauge 20-centimeter Mila catheter, fenestrated up to about an 8-centimeter marking. This enabled continued drainage of effusion without additional sedation for these patients while their stay in hospital. The objective of our study was first to develop a consistent pericardial effusion model that would simulate clinically significant fluid accumulation. My goal was then to place these PleuralPort catheters within the pericardial space using nothing more than a modified Seldinger's technique. In this study, we used 11 male intact beagle dogs that were attained after euthanasia for reasons unrelated to this study. They were stored at 45 degrees Fahrenheit and then warmed to room temperature prior to testing. In order to create these models, I performed a left-sided fourth intercostal thoracotomy and then placed a 16 to 20 gauge IV catheter within the pericardial space. I attached a T-port to continuously infuse saline as needed, and then sutured this catheter to the body wall using a 3-aught monofilament suture. Model creation and procedure were performed within 48 hours of euthanasia to better simulate the fibroelastic property of the pericardium and better simulate a clinical situation. I also standardized the pericardial effusion models by creating a standardized working space of approximately 1 centimeter measured on the fast scan unit I was using, with an average of 110 mils of saline being infused into each model. So in order to perform that technique, I had some sterile saline, a 10 blade in order to make the initial skin incision, a 14 gauge angiocatheter. I chose this one specifically just due to availability, knowing that this was the actual catheter that they used downstairs in our ER, an 0.35 centimeter guide wire, an 8 and 9 French dilator borrowed from some central venous line kits, and the 7 French PleuralPort model kit. The reason that we used a dilator was because of the blunt-ended tubing in the PleuralPort system itself. And we were worried that perhaps maybe it wouldn't pass as easily without first being introduced with a dilator. The models were placed in sterile recumbency to replicate a clinical situation that similar to what we would do in a pericardiocentesis. And the bedside ultrasound unit was used to evaluate the effusion and then also to confirm placement of the angiocath itself. To further demonstrate the technique, you'll see that here on the left will be a more representative picture of what it would look like in a true clinical situation should you be performing this procedure, and correlating intrathoracic pictures on the right side. I first created a skin incision using a number 10 blade and passed this 14-gauge angiocatheter into the pericardial space, which I then confirmed with ultrasound. I then passed the 035 guide wire and removed the angiocath over the guide wire. Sequentially passed both dilators into the pericardium, and then successfully was able to pass the PleuralPort tubing with a little bit of a twist in order to get it in. The procedure length was defined from that initial skin incision to the guide wire removal after the PleuralPort tubing was placed. What was not included was the tunneling of the PleuralPort tubing itself within the subcutaneous tissues, as well as the hub placement. The mean duration of the procedure was approximately 6.7 minutes, with standard deviation of 2.3 minutes. Complications that I found in my study was that during case 2, the PleuralPort tubing could not be advanced beyond 4 centimeters, whereas my goal was to place approximately 10 centimeters within the pericardial space. And upon confirmation, with every case, I performed a right lateral thoracotomy to confirm placement. I found that there was a myocardial puncture, and I determined that this was due to an inadvertent reverse loading of the guide wire. So moving forward with all the rest of my cases, I ensured that the J-tip was in fact the tip that was being passed. And I also pointed my initial catheter placement and guide wire placement in the caudo-ventral direction once I was within the pericardial space itself. To ensure that this in fact was the case, I performed an 11th case where I repeated the procedure without any noted complications. And then after I confirmed placement, I actually tried to intentionally puncture the heart with the J-tip of the guide wire, and it was not possible to do so. So I thought that my initial complication was just a technical error. Potential advantages to this procedure include the fact that it's much more minimally invasive than something like a thoracoscopy and pericardial window, and therefore has much less morbidity. These guys would be theoretically much more comfortable. It's nothing more than what a pericardiocentesis would involve, and so therefore potentially they could go home even earlier as long as they don't have any associated complications. I was able to perform this procedure in a relatively small working space of approximately 1 centimeter. So theoretically, should an animal have a pericardiocentesis performed before this procedure, could we potentially place this anyway with just a small sliver of effusion left over? Given that our procedure length itself was only approximately about 6.5 minutes, theoretically this could have a very short anesthetic window. And because this anesthetic window would be much shorter, as well as minimal use of other supplies, could we potentially cut the cost of this procedure? And based on my research and the prices that we currently have in our hospital, it would cost approximately half of what our thoracoscopy and pericardial window would cost. Because it has the actual silicone hub within the subcutaneous tissue, this would enable owners to be able to provide relief at home. Fenestrations in the tubing may act as an egress as well for the effusion to drain into the pleural space, depending on how many fenestrations are within the pericardium itself. So could these animals just resorb this fluid and not have to have it necessarily tapped by the owners? Some potential disadvantages to this procedure is lack of visualization of the pericardium for potentially very small lesions that are not picked up by echocardiogram, such as the mesothelioma shown in the picture here to the right. That also means that we are not able to obtain any biopsies, and we also don't know how arrhythmogenic this catheter placement could potentially be, though in the studies previous that say there's no difference between pericardiocentesis and a long-term catheter. Obviously, the long-term catheter in that case was only 3 to 4 days. So could potentially there be more irritation and arrhythmias long-term, as well as occlusion of the tubing itself and then infection as well. Some limitations to this study specifically is that it was a relatively small sample size, and of course that using the ex vivo models, we had a lack of clinical cardiac and pulmonary motion that we would have to compensate for. This procedure does have a lot of potential, but it will be important to consider patient selection and underlying etiology of the pericardial effusion going forward. Further studies would also be needed to compare this technique to other surgical techniques, to figure out truly the difference in average of hospitalization time and cost. Is there a difference in median survival time? And then potentially rates of complications as well. In conclusion, the percutaneous placement of the PleuralPort system is technically feasible. Utilization of this technique in the future could potentially offer a minimally invasive long-term therapeutic option for these owners for drainage and also relief of tympanoid symptoms. And with that, I'd like to thank my mentor, Dr. Hardy, for all of his help on this project, as well as Dr. Gunderson and Tina Wall for helping me accumulate all of these supplies and getting everything started for me. So thank you so much. And with that, I will take any questions.
Thoracostomy tube placement is a simple life-saving procedure which is commonly used to remove air or fluid out of the thorax. Other indications for thoracostomy tube placement are the need for repeated lavage of the thorax, postoperative monitoring of fluid or air production, and thoracostomy tubes can be also used for the intracavitary application of chemotherapy or analgesia. There is a large variety of tubes available on the market, including large or small bore tubes, which can have blunt or sharp tips. These are inserted through a small skin incision, then advanced subcutaneously and inserted into the thorax using blunt force, a stylet, or even a small hole performed with a curved hemostat. Other drains frequently used or are over-the-wire tubes, which are inserted using a modified Zeldinger technique. An introducer catheter is tunneled cranially and inserted at the cranial aspect of the desired drip into the thoracic cavity. The stylet is removed and J-wire inserted through the catheter. The catheter is then removed and the thoracic drain is inserted over the guide wire, which is retrieved afterwards. Feeding tubes or other closed suction drains can be converted into thoracostomy tubes. These are usually used during open surgery for short-term postoperative fluid or air evacuation from the thorax and are placed under visual control. The cited complication rate in veterinary literature is as high as 22%. However, no matter if single case reports, experimental ex vivo, small prospective clinical trials or retrospective studies, it seemed that there is no consensus regarding the classification of the complications in thoracostomy tube placement and use. Thus, comparison between the different methods or tubes is very difficult to almost impossible. In the absence of a standard reporting system of complications, Jonathan Aho and colleagues established and published standardized format for reporting complications for placement and use of thoracostomy tubes in human medicine, providing more clarity for reporting complications. So with that in mind, the objective of our study was to establish a similar standardized method to identify and classify complications associated with thoracostomy tube placement and use in veterinary medicine, as well as to compare complications identified by this method between different tube types. So we hypothesized that different thoracostomy tubes would have different complications, and the blindly placed tubes, respectively, those placed with the use of a trocar or guide wire, would have more insertional complications. For that, we conducted a single-center retrospective study, collecting data over the past 10 years from client-owned dogs and cats that underwent thoracostomy tube placement for various indications. And patients with thoracic port placement or incomplete information regarding surgery and aftercare during the hospital stay were excluded from the study, as well as other species other than cats and dogs. Data collected included the primary disease, concurrent surgical procedures, uni or bilateral thoracostomy tube placement, open or closed technique, type of tube, associated complications, the time to occurrence of complications, whether this was intraoperative or in the first 24 hours after placement, and also the outcome of our patients. So the complications were classified similar to the scheme used by Aho and colleagues in the following groups. Insertional being due to injury of structures, intrathoracic and extrathoracic upon placement, or immediate arrhythmias. Positional, which were complications caused by kinking, erosion into structures at least 1 day after placement, compression of structures, subcutaneous placement, abnormal position on immediate radiographic images, leading to correction of the thoracostomy tube placement. Then we had the group for removal complications. These were all the complications that occur really shortly after the removal, like acute bleeding, pneumothorax, subcutaneous emphysema that did not have been noticed until the removal, also retained foreign objects, or even pulmonary tissue herniation. Infective and immunologic drain site infection, pyothorax evolving after placement, necrotizing fasciitis, or local discharge from drain site. Then we had the group for instructional, educational, or equipment related. These were malfunction of equipment due to not having the tube correctly connected to the rest of the equipment, loosely placed fixation, sutures needed to be replaced, problems due to aftercare education, improper setup, improper use of Heimlich valve, or incorrectly dressing of the thoracostomy site. And as an additional classification group, we added self-mutilation related. These have been the complication that occurred due to on-purpose removal of the tube by the patient, or even partially removal or being destroyed by biting through or even biting it off. Regarding our results, we had 355 animals that met the inclusion criteria, with a total of 205 dogs and 150 cats. This meaning a total of 476 strains that were placed, with 234 being unilateral and 242 being bilateral. The main types of tubes were wide bore with blunt or sharp tips, over the wire inserted, feeding tubes, and wound drains. So in our statistic results, there was a significant worse outcome in cats, with 26% of them not surviving to discharge. There is also a significant worse outcome in closed versus the open technique, with 30% of them not surviving to discharge. But nevertheless, the incidence of complications was not significant for the outcome, neither was the drain type. So the overall complications for all drains were 7% for insertional, 33% for positional, 8% removal, infective and instructional 19% each, and 5% for the self-mutilation group. Insertional complications had significant worse outcome for blind technique, and positional and self-mutilation related complications were significantly more often in cats. Furthermore, cats had higher overall complications in the first 24 hours after the tube placement. Wide bore drains had significant higher complications within the first 24 hours. And although the over-the-wire drains had a higher percentage of insertional complications, this was not significant. So when looking at the overall complications, there was also no significance between the different type of drains. And we saw that the closed technique had significant more complication than the open technique, which was done under visualization. The most frequent complication associated with the placement of over-the-wire and wide-bore tubes were positional, infective, and equipment-related. Feeding tubes and wound drains were most frequently associated with infective and equipment-related complications. However, those drains had significant fewer positional complications compared to all other drain types. And these results regarding the overall complications showed the need for strict adherence to the proper technique during placement, as well as the need for meticulous aftercare of these patients. We suspected that the significant lower positional complication rate associated with feeding tubes and wound drains placed into the thorax are because these drains are more often used under direct visualization during concurrent surgical procedures. Regarding the outcome, it seems that this was not influenced by the thoracostomy tube type, but by the species and also by the placement technique.
So in our available data, we also have seen that cats seem to be more prone to complications than dogs. Regarding the conclusion of our study, we saw that the proposed classification of complications associated with thoracostomy tube placement and use provided an overview of prevalence of complications. All the occurring complications could be included in one of the classification group. This classification can really ease the comparison between different methods and also between different tubes, but further investigation and prospective studies are needed to identify risk factors for different types of complications. Regarding the limitation of our study, these are due to its retrospective nature, with some of the biggest issues being the lack of homogeneous distribution of drains, also different concurrent procedures with different underlying causes for the thoracostomy tube placement. With that, I would like to thank my colleagues for their support to make this study possible, and I would also like to thank the Soft Tissue Society for giving me this great opportunity to present our work. Thank you very much for your attention. I am happy to answer any questions. Thank you.
A 6.5-year-old 6.1 kilogram spayed female short-haired Chihuahua was referred to the soft tissue service at Kansas State University for surgical removal of a recurrent mast cell tumor in the right perineal region. The mass was initially incompletely excised 8 months previously, and histopathology results were consistent with a low-grade mast cell tumor. Local recurrence of the mass was cytologically confirmed by the primary veterinarian 4 months later. On physical exam, a 4 centimeter by 5 centimeter soft tissue mass was present in the right perineal region. Due to the size and location of the mass, it was elected to administer neoadjuvant vinblastine and prednisone to try to cytoreduce the mass. The mass initially responded to the medications, but then it returned to its prior size and was no longer responsive to chemotherapy, so it was decided to pursue surgery. Packed cell volume and total solids were measured at 48% and 8.2 grams per deciliter preoperatively. The mass was removed with 2 centimeter lateral margins and 1 fascial plane deep. An ipsilateral caudal superficial epigastric skin flap was elevated to the level of the second mammary gland and rotated to cover the surgical wound. Skin edges were opposed with a 2-layer suture closure, and a Jackson-Pratt drain was placed underneath the flap and maintained for 3 days postoperatively. At day 5 postoperatively, the distal 25% of the skin flap showed evidence of venous congestion severe enough to lead to concerns about tissue viability, as seen in the picture here. Numerous methods have been described for preventing venous flap congestion and necrosis. These include sildenafil, a PDE5 inhibitor, which leads to increased vasodilation and inhibits platelet aggregation, as well as medications that have anti-inflammatory and free radical scavenging effects, such as dexmedetomidine, topical nitroglycerin, and calcitriol. Studies in laboratory animals have shown improvement in flap survival with these agents, but administration is typically started immediately after or even slightly prior to surgical flap creation. Ischemic preconditioning of flaps can also be performed. In veterinary medicine, this is most commonly done by partially raising a subdermal plexus flap and suturing it back to the donor site 10 to 14 days prior to the definitive surgery. However, it has also been described in experimental animal models of axial pattern and myocutaneous flaps. In these situations, the pedicle is clamped and unclamped for 10 minutes at a time, back and forth for about a 1-hour period prior to suturing the flap into its recipient bed. Once venous congestion occurs, as was the case in our patient, options are more limited. Glucocorticoids and hyperbaric oxygen therapy have both been shown to be of minimal use in experimental studies. Pentoxifylline, a rheological agent that increases red blood cell distensibility, has been shown to improve skin flap survival when given immediately postoperatively, and some evidence exists that it may have benefit if administered after development of venous congestion, but there is conflicting evidence in the experimental literature. In human medicine, a superficial vein in the flap can be catheterized to allow intermittent drainage. Alternately, the vein can be anastomosed to a deeper regional vein using microvascular surgical techniques. However, these methods would be challenging in veterinary species. Negative pressure wound therapy has been used in the human literature to increase local blood flow and venous drainage and to decrease edema, leading to a decreased interstitial pressure, and this has been shown to have high success rates. It's also been described in a case report in a dog with nearly full flap survival. However, application to the affected area in our patient was deemed to be impractical due to its location near the anus and the tail base, and as such, the method we chose to employ was medicinal leeches. Leech therapy involves the use of Hirudo medicinalis to remove congested blood both actively and passively. Leech saliva contains more than 100 bioactive compounds with anticoagulant, vasodilatative, thrombolytic, anti-inflammatory, and analgesic properties, which maximize blood flow and make the blood ingestion pain-free for the host. The most well-studied of these substances is Hirudin, which inactivates thrombin already bound to a thrombus, as well as inhibiting factor 10A, preventing conversion of prothrombin to thrombin. Each leech can ingest 5 to 8 milliliters of blood per feeding, but prolonged bleeding from the attachment site can be present for up to 48 hours after the leech is removed, which is responsible for the main therapeutic effect of leech phlebotomy. It has been determined that continued hemorrhage from a single leech site can lead to a loss of 50 to 100 milliliters of blood in an in vitro human study. The number of leeches to use and duration of leech therapy for flap salvage are adopted from human literature. In most recent review papers of medical leech therapy in human medicine, it is recommended to use 1 leech per 3 to 10 centimeters squared of surface area. In human medicine, frequency and duration of leech therapy is highly variable, having been performed for a total of 4 to 22 days, with treatments repeated at intervals from hourly to once a day. Data about the frequency and duration of treatment is lacking in veterinary medicine, and treatment is evaluated on a case-by-case basis. In the 2 reported veterinary cases, the leech therapy was performed once daily for 4 days. The success rate for use of Hirudo therapy for flap salvage in human medicine has been reported to be ranged from 65% to 85%, but no information for success rates exists in the veterinary literature. Medical leech therapy was performed on our patient 6 days postoperatively with the use of 3 medical leeches as seen in this picture. The dog was not sedated. All 3 leeches were successfully attached and were left in place for ingestion for 30 minutes until they voluntarily detached. A bandage consisting of hydrophilic foam secured to the skin via an iodine dressing was applied. The dog was monitored for approximately 10 minutes and then was returned to the wards. 3 main complications of leech therapy have been described in the human literature. The first is the psychological distress that some human patients face at the application of leeches. To obviate this, a variety of chemical alternatives to leeches have been developed, typically involving the subcutaneous injection of heparin or other anticoagulants, combined with the mechanical puncture of the skin flap with hypodermic needles. Systemic anticoagulation may or may not be initiated as well. While these methods have proven to have similar efficacy to leeches, they can be labor-intensive and require frequent assessment to stimulate bleeding. These so-called chemical leaching methods have not been investigated in veterinary patients, and while they may represent a viable alternative to leeches, psychological distress is not a likely issue in our patients, even with the fragile psyche that our Chihuahua patient demonstrated. Local infection can occur after leech therapy because the intestinal tract of leeches harbors multiple bacteria, notably Aeromonas. Prophylactic antibiotics are therefore recommended prior to initiation of leech therapy, typically fluoroquinolones. In human medicine, the reported incidence of infection ranges from 2.4 to 36.2%, but no such information is available in veterinary medicine. Antibiotic prophylaxis was administered at the time of leech therapy in our patient using enrofloxacin, and this was continued for 3 days, with no evidence of local infection being observed. Blood loss is the final complication that has been described with medical leech therapy. Excessive blood loss can result in iatrogenic anemia, and transfusion may be needed. In human studies, 50 to 58% of patients required blood transfusion, possibly due to the prolonged and repeated treatment regimens that we've already discussed. Despite the high incidence of transfusion in human medicine, no cases of significant blood loss have been described in the veterinary literature, at least until I became involved. Approximately 1 hour after leech therapy, our patient was checked and a large amount of blood was noticed in the cage. At the same time, the dog was noted to be profoundly lethargic. A physical exam revealed pale mucous membranes, hypothermia of 93.1 degrees Fahrenheit, and tachycardia of 160 beats per minute. PCV and total solids were measured at 15% and 4.2 grams per deciliter. The dog was immediately blood typed and transferred to our intensive care unit. A 100 milliliter packed red blood cell transfusion amounting to 16 mils per kilogram was given over the next few hours. Post-transfusion PCV and total solids were 33% and 5.2 grams per deciliter. The dog had no additional hemorrhage from the flap during or after the transfusion. Recovery was rapid after the transfusion, and the dog's vital parameters returned to within normal limits immediately after the transfusion was completed. The dog was discharged 8 days postoperatively, which was 2 days post-leech therapy. At the time of discharge, the skin flap was alive, and the dog was having no additional clinical signs of anemia. Histopathology of the mass removed was consistent with a high-grade mast cell tumor with complete but narrow margins. On recheck examination 26 days postoperatively, the skin flap had healed and was noted to have 100% flap survival, as seen in the picture here. So at least our therapy did have benefit to it. Based on this case, it might be a good idea to take additional precautions after leech therapy, especially in small patients. A packed cell volume should be performed prior to leech therapy and again afterwards if there is concern about excessive blood loss. For small patients or those with comorbidities that might lead to increased blood loss, blood typing should be considered, and a source of blood transfusion should be available. While ongoing blood loss from leech attachment sites is desired, and in fact can be encouraged by wiping with heparin-soaked gauze, in cases where there is excessive hemorrhage, consider placing a compression bandage to the treatment site to facilitate hemostasis. And in all cases, it would be a good idea for the patient to be monitored closely for mucous membrane color, heart rate, and respiratory rate for up to 48 hours post-leech therapy, or at least until bleeding from the attachment sites has stopped. Thank you for watching this presentation. Hopefully it has some useful information or can stimulate a discussion about leech therapy and venous congestion.
This patient first presented to its primary care veterinarian with a chief complaint of a decreased appetite, weight loss over multiple months, and a mild weight-bearing right forelimb lameness. Otherwise, he had a pretty unremarkable history for his 15 years of life. On physical exam, his primary care veterinarian did not detect any abnormalities. They ran several diagnostics, including a CBC, baseline T4, urinalysis, and urine culture. All were within normal limits. The chemistry panel showed a mild azotemia, which was assumed to be prerenal in origin, as it had a normal SDMA. The patient returned a week later for thoracic radiographs, which showed a lytic lesion on the caudal border of the right scapula, as well as a possible pulmonary nodule. The primary care veterinarian was concerned about a primary bone tumor and started medical management with gabapentin and referred them to a local oncologist. 10 days after his initial presentation to his primary care veterinarian, the local oncologist performed their own physical examination and also determined there to be no abnormalities. Staging for the suspected bone tumor seen on thoracic radiographs consisted of CT scan of the thorax, forelimbs, and abdomen. Imaging revealed a large, expansile, irregularly mineralized mass centered over the caudoventral scapula at the site of attachment of the infraspinatus muscle. The mass did not extend to the scapulohumeral joint or beyond the dorsal and mid portions of the scapula. A thin wall of bone surrounded the stippled, irregular internal mineralization. No pulmonary parenchymal lesions were described, and the previously reported pulmonary nodule on the thoracic radiographs was differentiated as a Bates body. Benign etiology was prioritized for a 1.8 centimeter in diameter rounded mass noted in the left adrenal gland. Fine needle aspirates were taken of the scapular mass at the time of anesthesia, and cytology was consistent with morphologically unremarkable marrow tissue with an absence of neoplastic cells. Several different treatment options were discussed, but ultimately the owners elected for a second opinion. Therefore, they presented to our institution a month and a half after initial diagnosis. On physical exam, we detected a grade 3 out of 6 left parasternal heart murmur, as well as, over the right scapula, a mild to moderate muscle wasting and palpable firm bony mass measuring approximately 3.5 by 3 centimeters. When the patient ambulated around the room, there was a notable 3 out of 5 right forelimb lameness. A CBC count and chemistry panel were repeated and were clinically unremarkable. An ultrasound of the left adrenal gland showed that the mass was static in size. An echocardiogram was also done considering the new auscultation of a heart murmur, and the result was consistent with a benign murmur. Diagnostic and treatment options were discussed, including surgical biopsy to obtain a definitive diagnosis of the scapular mass, 4-quarter amputation, scapulectomy, and palliative radiation therapy. Ultimately, the owners elected to proceed forward with a total scapulectomy. The patient presented a few days later and was placed in left lateral recumbency. A 10-centimeter incision was made along the right dorsal scapular spine to the level of the humeral head. Local muscular and tendinous attachments were elevated from their origin or cut prior to transection of the glenohumeral joint and subsequent removal of the scapula and associated mass. The glenohumeral joint and ligamentous attachments were tacked to the periosteum of the first rib with a single interrupted horizontal mattress suture using 2-aught proline. The muscles were opposed with 2-aught proline and 2-aught PDS and horizontal mattress in simple interrupted patterns respectively. The subacute tissues were opposed using 2-aught PDS, and skin was opposed using 3-aught monocryl and 3-aught ethyl-1. The entire scapula and associated mass were submitted in 10% formalin to our histopathology service for evaluation. Within a few hours after surgery, the patient was attempting to ambulate using the right forelimb. Due to his inability to bear weight without collapsing, we did place a modified Robert Jones bandage to his right forelimb and a wrapping around his thorax to provide support for continued ambulation. This was removed 5 days later after the patient represented on recheck for a swollen right front paw. At the time of suture removal on October 30th, 17 days postoperative, the incision was healed and all swelling of the right front paw was resolved. And as you can see in this video, the patient was comfortably ambulating on all 4 limbs with only a mild gait abnormality. Our histopathology service examined 5 representative section samples of the resected mass stained with eosin and hematoxylin. Bony trabeculae were extremely thinned and surrounded by skeletal muscle. The intraosseous space was expanded by lobules of well-differentiated adipocytes with large clear vacuoles replacing the cytoplasm with peripheralization and compression of the nuclei. In general, the samples had a lack of bone marrow elements and trabeculae had evidence of remodeling due to compression, as evidenced by thin basophilic seams or lines along the edges. An intraosseous lipoma was diagnosed based upon the clinical, radiographic, and histopathologic findings. Feline primary bone tumors are quite uncommon, with 4.9 per 100,000. Of those, up to 90% are malignant. There are several different types of feline primary bone tumors, the most common being osteosarcoma. The radiographic changes seen with osteosarcoma, including osteolysis, corticolysis, and new bone formation, parallel the radiographic changes that we observed in this case. In addition, the location is commonly appendicular and is often locally invasive without signs of metastasis. However, while both osteosarcoma and intraosseous lipoma originate from the bone, the histologic characteristics seen in this patient excluded osteosarcoma due to the absence of osteogenic cells, multinucleated giant cells, and local invasion into blood vessels. Another considered differential was chondrosarcoma, which is a tumor type that can frequently affect the scapula and is considered the second most common primary bone tumor in cats. Histologically, they are uniquely characterized by interwoven bundles, sheets, and nests of cells within basophilic chondroid matrix, features that we did not appreciate on histologic examination of the mass in this case. Other considerations were fibrosarcomas, angiolipoma, hypertrophic osteopathy. However, they were all able to be ruled out on the basis of radiographic and histopathologic evidence. When writing up this case report, I often did have to refer to the human literature considering the rarity of intraosseous lipoma in the veterinary literature. In people, while still rare, intraosseous lipomas are radiographically characterized by a sclerotic rim surrounding an osteolytic lesion in the medullary canal of bone, similar to the radiographic description in our case. In addition, on histopathology, these masses are commonly described as densely packed, mature, non-mitotic adipocytes with fibrovascular stroma that are locally infiltrative, often without invading vasculature or periosteum, again similar to as described in our case. I also wanted to address the only reported case in the veterinary literature that described an intraosseous lipoma in a 2-year-old female intact Leonberger. Similar to our case, the patient presented for a history of chronic lameness in the right forelimb that was refractory to medical management. Physical examination revealed a semi-firm, soft tissue swelling extending from the right elbow to the carpus. Radiographs showed extensive cyst-like osteolysis of the diaphyseal of the ulna and distal metaphysis of the radius. The mass and associated periosteum were surgically resected and submitted for histopathologic interpretation, which again was similar to our case, allowing us to kind of arrive at this more difficult diagnosis. In conclusion, with patient follow-up following wide surgical omission by means of complete scapulectomy, our patient did regain function of the limb and has been free of disease for 4 months as of his last recheck, and I'm happy to report he's still really doing well. In addition, we also wanted to encourage the consideration of intraosseous lipoma as a differential diagnosis in future cases with similar signs in history, especially considering the rarity of primary bone tumors in cats already. Here are a few selected references. Then I also wanted to open up this to questions, as well as thank Dr. Jennifer Huck of the Surgical Oncology Service and Dr. Church of our Histopathology Service for all their help with this case.
This case follows Harley, an 8-year-old male castrated golden retriever, who presented for evaluation of a left thoracic limb lameness. He had been adopted from a shelter 6 weeks prior. The duration of his lameness was unknown, as was his history and possible inciting cause. On physical exam, he had a grade 2 out of 4 left thoracic limb lameness, and along the left proximal medial radius, there was a firm to bony lesion with an associated soft tissue swelling. Orthogonal radiographs were performed, which documented a smooth to lobulated bony lesion arising from the left proximal medial radius. And based on these radiographs, there was no cortical nor medullary involvement seen. On oblique views, the lesion did not seem to invade the medullary cavity as well. Based on the radiographs, baseline blood work and 3D thoracic radiographs were performed. There was no evidence of metastatic disease at the time, no abnormalities on blood work, and so an excisional biopsy was recommended and performed. At the time of excisional biopsy, the mass appeared to arise from the periosteum, was very friable, and was noted to be intimately associated with the interosseous artery. Hemoclips were used to achieve hemostasis, and post-operative radiographs showed seemingly gross excision of the mass that's seen on radiographs preoperatively. Histopathology diagnosed an osteosarcoma with an unusually well-differentiated appearance, with spindeloid to polygonal cells, an abundant cartilage matrix, and a very low mitotic rate. Upon further review of the lesion in consideration of the radiographs and further discussion with the surgeons, a final diagnosis of parosteal osteosarcoma was made. Based on the findings, a computed tomography or CT scan was performed to evaluate the true extent of disease and to facilitate surgical planning. A limb spare or radical excision were under consideration, and CT scan findings of medullary involvement and a hyperattenuating lesion within the soft tissues associated with the left proximal medial radius indicated that there was residual disease that was far more extensive, and so radical excision via 4-quarter amputation was performed. Histopathology confirmed a diagnosis of parosteal osteosarcoma with normal margins and a normal lymph node. And given that the literature available at the time documented veterinary patients who had metastasis at the time of diagnosis, Harley was treated more aggressively with a chemotherapy protocol of carboplatin, even though he did not have evidence of pulmonary metastatic disease on his preoperative thoracic radiographs. Serial thoracic radiographs were performed throughout his chemotherapy and for over 1 year following his treatment, and ultimately he was lost to follow-up after having done well. On representation over 2 years from the time of diagnosis, 3D thoracic radiographs showed a diffuse small pulmonary nodular pattern that was concerning for metastatic disease. And serial 3D thoracic radiographs over the next year documented progression of pulmonary metastasis. In summary, Harley was followed up for over 3.5 years from the time of diagnosis until he was humanely euthanized due to progression of disease. Osteosarcoma, the most commonly diagnosed primary bone tumor in dogs, can be divided into 2 different categories. Conventional osteosarcoma, or endosteal or intraosseous, being one category, and periosteal osteosarcoma includes parosteal and high-grade surface osteosarcoma. In humans, a more aggressive form of parosteal osteosarcoma is described, known as dedifferentiated parosteal osteosarcoma. Parosteal osteosarcoma has been reported in dogs between 7 and 14, with no known breed predisposition, likely due to the small number of cases reported. And history varies in comparison to endosteal osteosarcoma in that there is often a slow-growing, firm mass, plus or minus lameness depending upon the location and the size of the lesion. And often parosteal osteosarcoma can be either painful or non-painful in comparison to endosteal osteosarcoma, where patients are likely more painful and more pain. Parosteal osteosarcoma often appears as a smooth to lobulated lesion on radiographs, whereas endosteal osteosarcoma often affects the medullary cavity, has a starburst or more aggressive appearance. And parosteal osteosarcoma may or may not have cortical destruction and medullary involvement. And histologically, parosteal osteosarcoma can appear much more benign meaning that there is a lower mitotic figure rate seen. There is often sparse regions of sarcoma cells and well-differentiated cartilage. Treatment and prognosis for both types can be similar. However, prognosis for parosteal osteosarcoma can indicate a longer disease-free interval and mean survival time. In humans, radical excision can be curative. Metastasis may be seen within several months or up to several years following radical excision. In Harley's case, he did not have metastatic disease at the time of diagnosis, and he was treated very aggressively in consideration of the literature available at the time, indicating that veterinary patients did have metastatic disease at the time of or shortly after diagnosis. And so Harley represents the longest reported survival time for a canine patient diagnosed with parosteal osteosarcoma who did not have evidence of metastatic disease and who was then treated with chemotherapy. Parosteal osteosarcoma, in summary, can affect the same population as seen with endosteal osteosarcoma. There may be a soft tissue or soft tissue swelling associated, and radical excision may be curative for these patients and overall provide a better prognosis than conventional osteosarcoma. A special thanks to Dr. Laurie Allen and Dr. Gabby Spilliboy and to Harley. Thank you all for coming to my presentation, and I'm happy to answer whatever questions you may have.
The total ear canal ablation combined with the lateral osteotomy is generally considered to be the gold standard surgical procedure for dogs and cats for a multitude of indications. Some of those include auricular neoplasia, which is often an indication in our feline patients, oral cholesteatoma, severe ear canal trauma, or in the case of our canine patients, end-stage chronic otitis externa in media that is deemed unresponsive to medical therapy. Important to note that the normal ear canal does have its own microbiota, so Staphylococcus and Streptococcus species are pretty common. And then in cases of otitis externa, there can be secondary bacterial colonization by isolates such as Corynebacterium, E. coli, Pasteurella, to name a few. When performed successfully or properly, the TICA LVO shows a lot of improvement in patients in roughly 50 to 90% of them when performed for cases of otitis externa, but you have to keep in mind that in performing these procedures for that disease process, that it can be considered a salvage dirty procedure, given the presence of the microbiota, with infection-related postoperative complications being pretty widely variable, but it's been cited in 5 to 82% of patients, with the infection-related complications theorized to be secondary to either retained ear canal or middle ear epithelium or contaminated subcutaneous tissues at closure. Patients with chronic otitis externa generally present further TICA LVO with a history of systemic and/or topical antimicrobial administration, but in reviewing the literature, it didn't appear to be noted whether or not administration, either the choice, meaning empiric versus definitive therapy, and/or duration of these antimicrobials prior to TICA was actually beneficial or detrimental to these patients, which seemed fairly worth investigating given the concern for selection of methicillin-resistant bacteria with chronic antibiotic use. Our objective, or our main objective for our study, was to actually evaluate a large number of dogs and cats undergoing this procedure to document any relationship between antimicrobial choices perioperatively and the occurrence of infection and neurologic signs or complications following the procedure. A secondary objective of the study was actually to assess several other patient and perioperative factors that may or may not actually contribute to short and long-term complications in these patients. The null hypothesis is that the duration and choice, so empiric versus definitive, of pre and post antimicrobial administration would have no effect on the long and short-term complications in dogs and cats undergoing this procedure. This was set up as a multi-institutional retrospective. We analyzed cases from the University of Tennessee, as well as the Veterinary Specialty Hospital in Sorrento Valley, The inclusion criteria included dogs and cats undergoing TICA LVO for any reason. The follow-up material had to be available from the time of surgery to greater than or equal to 6 months postoperatively. The exclusion criteria basically removed any patient that had TICAs without LVOs, and again, we needed information from the time of surgery to greater than or equal to 6 months. The medical records were pulled from roughly a 10-year time frame. Data included preoperative information, which included the sigmoid physical exam finding, medications prior to presentation, preoperative blood work and diagnostic imaging. Intraoperative information included the procedure performed, so bilateral versus stage TICA LVOs, anesthesia and surgery times, histopath results, and then bacteria culture and sensitivities. And then regarding the post-op information, we categorized it into 3 time frames, so immediately post, which is in 48 hours, short-term, 48 hours to 1 month, and then long-term being greater than 6 months. We also included the post-operative treatments, such as the antimicrobial administered, the infection-related or neurologic complications, and the need for a revision procedure if infection-related signs were noted, and then the outcome of the patient. For the statistical analysis, descriptive statistics were calculated. We did also have our categorical data that was expressed as frequencies. And then with the logistic regression analysis, we used that to evaluate the effects of clinical indicators on the response variables, which included neurologic signs in the post-op period, infection-related signs in the post-op period, death or euthanasia related to infections of disease, and then need for a surgical revision procedure. And then significance was set at a p-value of less than 0.05. So there were roughly 120 patients enrolled for the study, 107 dogs, 13 cats, with a total of 149 TICAs. Of the 107 canine patients, 32 dog breeds were represented. Cocker Spaniels staying strong at the poster children for TICAs, with the mixed breeds, English Bulldogs and Labradors, being second, third, and fourth on that list. We did find that no variables were actually associated with sigmoid in regards to being associated with postoperative complications. The median weight for these patients was roughly about 14 kg, and this is dogs and cats included. That helped us to find was that for every additional kilogram increase in weight, it was found that the odds of infection-related occurrence increased. For the patients that were presenting for surgery, nearly half of them actually presented with a history of systemic antimicrobial administration, with half of those patients being given antimicrobials based on culture and sensitivity, a third of them receiving empirical antibiotics, and the remainder of them being given based on otic cytology. And then roughly 74 patients, 61% of them, were receiving topical otic antimicrobials prior to presentation. For both those types of medications, topical versus systemic, we found that preoperative use type, duration, and selection criteria was actually not significantly associated with any postoperative complications. With the cultures that were performed in surgery, so samples were obtained in 102 patients, growth of bacteria was appreciated in 86 of them, with 2 or more bacterial organisms being appreciated in more than half of those cultures. There are no growth in 15%, and then a quarter exhibiting growth in 1 microbe. The staphylococcal species were the most common isolate culture from over half of them, with 35 of those being positive for staph pseudo, and then nearly a tenth of those being methicillin resistant. Our data does suggest that positive cultures for Staphylococcus pseudointermedius and gram-positive organisms, those patients were likely to exhibit more infection-related complications following surgery. But interestingly enough, the presence or the number of organisms that grew, as well as the presence of methicillin-resistant organisms, was not associated with postoperative complications. Following the TICA LVO, empirical antimicrobials were administered in 92 patients, with 28 of them not being given empirical antimicrobials following surgery. For the patients that were not started on antimicrobials, only half of those actually had cultures collected at the time of surgery. And what we found is while those patients that weren't necessarily started on antibiotics after surgery weren't necessarily likely or more likely to get infection-related signs postoperatively, however, if cultures were performed at the time of surgery and those cultures were positive, we found that those patients who were not started on antibiotics within that short-term time frame, so between 48 hours to 1 month, those patients were more likely to have infection-related complications and require a vision procedure. For the patients that were actually on antibiotics, we found that with every additional month of systemic antimicrobials administered after surgery, those patients were more likely to be euthanized due to recurrence of disease and more likely to require a revision procedure. The overall rate of infection-related signs following TICA in our study was roughly about 25%, so a little under a quarter of patients, with just about a little over more than half of those patients having resolution of their infection-related clinical signs with medical management, so usually just continuing antimicrobials for a set amount of time. The other half needing some sort of surgical revision procedure to actually gain resolution of their signs. Again, in an effort to accomplish our secondary objective, we evaluated again several patient and perioperative factors associated with complications, which found these factors specifically to be significantly associated with infection-related signs, those including discomfort when opening the mouth, evidence of osteomyelitis or lysis of the bulla on CT, or otitis interna on CT. Regarding our neurologic signs, in this study, the overall rate of complications about 55%. We then, from there, categorized them as either being transient, so temporary, or permanent, with transient signs being those that were present within the short-term post-op period, but then absent for subsequent follow-ups, and then the permanent neurologic signs being present throughout all the way to long-term. What we found is that both dogs and cats did exhibit similar temporary neurologic signs, with both around 40%. However, cats did exhibit a higher percentage of permanent neurologic signs, roughly 7%, compared to dogs at just under 3%. Again, the factors that we found to be significantly associated with neurologic signs postoperatively included neurologic signs of presentation, unilateral disease of presentation, histopath being consistent with inflammatory disease, intraoperative hyperthermia, bullae that were flushed with hypochlorous acid, as well as the diagnosis of a cholesteatoma. This is a nice graph that really summarizes the overall occurrence of both infection-related and neurologic signs found in our study, and then their predominance within the short, intermediate, and long-term post-op period. As you can see, neurologic signs were the highest immediately after surgery in the short-term period, with roughly 92% of patients exhibiting complications being neurologic, and then in the long-term, infection-related signs were predominant. Overall, the study does seem to support the use of postoperative antimicrobial administration following the TICA alveolar procedures, especially in the cases with postoperative intraoperative cultures. While the duration of these antimicrobials to be administered for a positive culture was not determined, there does seem to be a poor correlation with longer durations of these medications being given, which we assume to be reflective of how severe the disease process is, necessitating continued use. These findings do allow for us to project our hypothesis, stating that perioperative antimicrobial use would have no effect on postoperative complications. The complication rates reported here are actually fairly close to those in the literature. So our short-term complication rate was about 58%. So those previously noted were about 21 to 82, again, with neurologic signs predominating in the short-term period. And then the percentage of long-term complications here is actually fairly optimistic compared to those reported, with ours being about 11%, and those being about 22 to 40%. And again, with infection-related signs predominating the long-term post-op period. This study did provide the rate of revision procedures following infection-related clinical signs, which is not one readily found in the literature. It also emphasized the percentage of patients with infection-related clinical signs showing resolution with either medical management versus surgical management, which is essentially a flip of the coin, being 50-50. Some study limitations. So it had several limitations being inherent to most retrospective studies, including details in the medical records being more complete than others, owner recall bias, inability to control treatments administered, and variability in follow-up time. Given the strict inclusion criteria of only including patients with long-term follow-up greater than 6 months, it is possible that we missed some in the short and intermediate follow-up period, but in evaluating those, we only lost, I think, collectively 6 patients. So I don't think it affected our data too much. The relatively small size of the study population also limited a few meaningful comparisons, specifically the small number of cases that required either revision procedures, involved cats, or patients with cholecystoma. So in conclusion, the vet literature seems to be fairly limited regarding the utility of antibiotics to prevent postoperative complications in patients undergoing TICAs. This study did find no association between the duration and choice of antibiotic administration and the incidence of infection recurrence. However, do advocate for administration of systemic antibiotics within the first month following surgery, which should be needed to prevent long-term complications when cultures are positive. Again, although duration cannot be determined from the study, it is fairly apparent that the use of them postoperatively does play a role in successful outcome. Again, several other useful conclusions were also drawn, including the identification of factors with severe disease, being more specifically those noted within the diagnostic imaging, that should prompt the clinician to warn owners of increased risk of complications. This study, we believe, also illustrates the continued relatively high rate of infection-related complications following TICA LVO and incidence of infection-related clinical signs requiring revision. And hopefully, this study will provide clinicians with additional information so that appropriate owner counseling and on complications and risk of the TICA LVO procedure can occur. With that being said, that concludes my presentation. So I guess we'll open the floor for questions. A big thank you again to the people mentioned below. So more specifically, Dr. Lux has been super instrumental in helping me with both the paper and its presentation, as well as some with statistics. And Dr. Fryer and Dr. Sumner have also been amazing in giving me their support. And then thank you all for allowing me to present. Thank you.
This story started in 2017. You know, one of these days when you are looking over internet how to sterilize my ligature forceps, then I found this Swiss startup company, which was 10 kilometers from me, actually. They have made a machine designed for human medicine, for, let's say, third country medicines and very small endoscopy centers. It was not designed for vets at the beginning. Ozone is a gas, O3. The name means smelling, and it's one of the most aggressive oxidating agents against microorganisms. Of course, ozone could be toxic, but the good thing is that you smell it, let's say 50 to 100 times before the toxic concentration, so there is a huge security margin. 2 words about sterilization. At least in Europe, sterilization means log 12 reduction of the germ Geobacillus stearothermophilus, which is the most heat-resistant microorganism and one of the worst-case scenario if you have it. This study done with a Danish machine, not using for sterilization, but for cleaning or eyelid disinfection. You see that there is a log reduction between 4 to 7 for some viruses or microorganisms. What you need to remember is that this study was done with an ozone concentration between 50 to 80 ppm. In the study we will present you later on, you will see that we reach ozone level or concentration far over, let's say, 500 up to 1000 ppm. Of course, this machine uses and produces ozone. The ozone is produced with 3 IV lights. Each light beam at a different angle, and the light beam goes across a glass quartz, which is at the top of the box. You will see just in a moment. And he used the oxygen inside the box to produce ozone. This machine also always measures the ozone level or concentration inside the box. So we have the complete knowledge about the ppm of ozone inside the box every minute, let's say something like that. How this machine works. So you put no chemicals inside, just 5 milliliters of still water. Then you see also the cover with in red with the quartz glass. Then you put the cover over the machine, and then the machine just below the lights. On the screen, you select the cycle, the user, or whatever you need to select. And then at the end of the process, the machines will give you a ticket with the number of the ppm or whatever, and the validation OK or non-OK. So the study design, it's an experimental study. The question we wanted to answer is technology efficient to sterilize ligature or caïman and piece in a 12 hours cycle of this Sterix machine. We chose 12 hours at the beginning because we had no knowledge about this, and 12 hours was the time supposed to have the complete sterilization. We decided to make bacteriological testing after a normal mini-invasive surgery and after a 12-hour cycle. We sampled two zones of the handpiece, the handpiece itself and the tip inside and outside the jaws of the caiman and the ligature. Instruments were in pouches inside the box. At the beginning, we put just one instrument alone in the box, and the instruments were new, completely new at the beginning. We sent the swab to an external lab to have a validation, and we also did plating for quick visual results. Sampling was done with two methods at the beginning: immersion in a sterile water and swab rub on the tip and the end of the ligature or the caiman. Here you have a picture with one ligature device into pouches and one with the caiman device into pouches also. That's exactly how they were put in the box of this machine. That's how I recorded the swab before and after the sterilization, so after the surgery, the cycle number, and then the visual indicator of the machine. Here are the results of one of the first cycle we have done for validation. As you can see, it's a little bit more than 12 hours, and as you can see also, the machine completely destroyed the ozone after the cycle. So when you open the box, there is no ozone at all inside. I had contaminated the instrument myself for this cycle, so the caiman and the ligature. And as you can see, you have sometimes pastoral, you have coliform, you have staphylococcus. And after the cycle, you cannot find any of these germs on the lab. And on the plating, on the left, there is some growth of germs. And on the right, there is no growth. So that was one of the cycles we used for the validation and to see if our hypotheses were correct. With the first cycle of 12 hours, with a concentration sometimes over 500 or 600 ppm of ozone, and the total dose of the cycle way more far than 1000 ppm hours. There were, of course, a learning curve of the machine, and the idea is to redesign the study. Quickly, we have this idea to find a recommendation for the vet market, how to sterilize the ligature and the caiman. So what we did exactly in the study I will present to you right now is putting the handle or the vessel sealing device in two pouches using a 3 hours cycle, because we could reach big ozone concentration, and then we were pretty sure that we could kill the germs. And we decided to put non-clean instruments, so instrument directly coming from the surgery without any rinsing, without any cleaning, without any disinfection, to have safety margin and to see if this machine is efficient enough to kill the microorganism. So these are the results we get from some of the cycle. It's from a caiman, as you can see. So you have the curve. So you see that the ozone level reached sometimes about 400 ppm inside the box. There is few contamination on the handle and the tip before, and on the right part of the slide, you see that there is nothing after the cycle. You see that you have a lot of bug and germs on the tip before the cycle, and then on the right and on the bottom part of the slide, you have nothing after the cycle. Picture to show you that the instruments were really non-clean at all before going inside the machine. And then ozone has this effect of cleaning and removing some of the debris and the fat, because on the top and on the bottom, there are no mechanical cleaning or rinsing or whatever. It's just what we put inside the box and what we get after the cycle. I had to make a break of 3 months during the study last year because of back pain. And I left one instrument sterile inside the box. As you can see on the cycle, it was not a very good cycle. The ozone production was not very good. We reached one, let's say 500 level, and then it really decreased very, very, very fast. This instrument stayed in the box for 3 months, and then we had no growth when I opened the box and sampled the instrument. It was a ligature. What we have seen is that the cycle is efficient with 3 hours, even with dirty instrument. We have seen that 1 or 2 pouches doesn't change anything in the process of sterilization, at least at 3 hours. and that the brand and the material or the design of the instrument doesn't change the efficacy. We have done this study with LigaSure, with Cayman. I have done also with Ensil of Johnson and with the Airway precision device. All these 4 vessel sealing devices showed us the same results. The company made improvement of the machine during the study, and then we could reach now very higher concentration of ozone. And then the idea was to find a ppm hours, so a total dose during one cycle, as a cutoff, rather than a timing or cycle timing duration. You can see here, we have also done 2 hours cycle with very good results of no growth after the cycle on the normal plating. We have also introduced this Biomérieux sample testing method. You can leave the sample inside the liquid, and the liquid should remain completely clear. And you can let the sample inside the liquid for 2 weeks. We have found few late contamination, not growing on the normal plate. And I will show you this few contamination on the graph just in a few slides. So one example of the cycle we can get now. So it was a Cayman device. You can see the colorimetric indicator. And then you can see that we can reach during one cycle more than 1000 ppm, the timing concentration. So this machine is really efficient. So in a 3 hours cycle, we can sometimes reach more than 2000 ppm. And remember the study they have done in Germany with 50 to 80 ppm. So another result we get with long time testing on the left, the plating and the ozone cycle concentrations. I have put this cycle because the ozone production was not very good in that cycle. And as you can see, we only reached something between 200 and 300 ppm. And nevertheless, with this concentration, we could kill the germs. Open question or open possibilities. For example, how long or which concentration should we use for a clean or rinse instrument? Because remember, all the instruments we have put inside this study were not cleaned or rinsed at all. And the potential use of the machine, we can put inside almost everything. Flexible scopes, doing the same study, same testing, and then I can see we have seen that we can completely sterilize this endoscope. Also the channel inside. So done this study on this new LigaSure device with the monopolar hook and the LigaSure tip, and both of them were clean and sterile after the 3 hour cycle. Some example of what I've put in the box, as you can see. Nowadays, we are using the machine in my clinic. We are putting a lot of things, different things, and a lot of pouches at the same time inside the box. To show you some of the results we got, I have to tell you that sometimes I have over-contaminated some tips of the device, and in few cases we didn't have a completely sterile device after a 3 hour cycle, but it was on really high contaminated devices. These are the results for the non-completely sterile. All of them were sterile on the plating, but the long-term liquid didn't come completely sterile. In conclusion, we can say that this machine is highly effective for sterilization of Cayman and LigaSure instrument. The shorter cycle we should use is around 3 hours, and the cutoff level is around 750 ppm. Remember, for non-cleaned and or rinsed or disinfected instrument. With normal washing or cleaning, the cycle should be even lower. And we can validate the question of the study that this machine is efficient for sterilization of LigaSure and Cayman instrument. Still doing further tests with highly contaminated instrument and a 4 hours cycle, because we do think that even for really high contamination, 4 hours is enough. The limitation is that we cannot have a control level of standardized contamination. What we are trying to do, or the company is trying to do also, is validation for flexible scopes. I really think that this machine is a revolution for us in the vet market. There are so many other possibilities like stent sterilization. I do sterilize mesh, polyethylene mesh inside the machine. And I guess, or I hope, it will be the end of the use of the chemical ATO replaced by the ozone. Thank you very much for your attention, and I hope we can see each other next year.
Axial pattern flaps, or APFs, are a common technique used in veterinary medicine to repair large skin defects. APFs include a direct cutaneous artery and vein, and it's the terminal branches of these cutaneous angiosomes that supply blood flow and sources of drainage to APFs. APFs allow for early closure of large defects with minimal tension, and they provide full-thickness, durable skin coverage to wounds. APF development in veterinary medicine was first described by Dr. Pavletic using radiographic mapping studies, shown in the top right image, to define anatomic landmarks for flap planning, shown in the bottom right image. Although overall survival rates of APFs range from 87 to 100%, complications can occur in up to 89% of cases. Many of these complications, such as flap necrosis, can be attributed to inadequate blood supply. Despite following recommended anatomic landmarks, patient regional variability in vascular anatomy may prevent appropriate incorporation of the perforating angiosome. Various imaging techniques, such as ultrasound, computed tomography angiography, and magnetic resonance angiography, have been developed to improve our preoperative APF planning. And while these methods contribute useful information, they lack the ability to be used intraoperatively with ease and can increase the duration of general anesthesia and cost of surgery. Other methods, like intraoperative fluorescein injections, have been used. However, this requires intraoperative darkness and the use of an ultraviolet Woods light. The pitfalls of these techniques have led investigators to evaluate alternative imaging modalities. Near-infrared fluorescence imaging, or NIRF, is a minimally invasive intraoperative imaging technique that functions in a timely manner, is non-toxic, and is easy to interpret. NIRF utilizes near-infrared light, which has an emission spectra different from that of visible light. Near-infrared imaging uses fluorescent contrast agents like indocyanine green and a specialized imaging system to visualize the fluorescent agent and tissue intraoperatively. The flowchart on the right depicts the imaging process itself, as well as a specific type of imaging system in the top right corner. Indocyanine green, or ICG, is a near-infrared fluorophore that was initially developed for retinal angiography, but its use has since been expanded significantly. Once administered intravenously, it almost entirely binds to plasma proteins, confining it to the intravascular space with minimal leakage. The normal plasma half-life of ICG is 3 to 4 minutes, and because of its wide use in human medicine, it has a well-known safety profile with very few reported adverse reactions. NIRF-A, or near-infrared fluorescence angiography with ICG, is currently utilized in human medicine to aid in the development and monitoring of skin flaps. Additionally, Quinlan et al. In VetSurg 2021 has published a case report documenting its use in the development of caudal auricular flaps in 2 cats. The overall objective of the study was to describe the use of NIRF-A using ICG for the real-time identification of direct cutaneous arteries and their associated angiosomes for APF planning and development in 2 dogs. The image on the right depicts the anticipated vascular fluorescence patterns, also known as VFPs, that we expect to see associated with each APF of interest. The first case was a 1-year-old female spayed mixed breed dog that was referred for evaluation of necrotic left pelvic limb. 4 days prior to presentation to our hospital, the patient was attacked by another dog. An initial wound debridement was performed by the referring veterinarian. However, the wounds progressively worsened. The image on the right shows a cranial view of the remaining quadriceps of the patient. A mid-diaphyseal femoral amputation was performed, and all necrotic tissue was sharply debrided, and the wound was lavaged. A tie-over bandage was placed over the wound, and daily bandage changes and debridements and irrigations occurred as needed for the next 5 days. 6 days after the partial limb amputation, definitive wound closure was performed using a right caudal superficial epigastric flap. On the left image, you can appreciate the size of the wound and the presence of healthy granulation tissue. The image on the right depicts caudal superficial epigastric flap margins drawn according to the current anatomic landmark recommendations. Prior to incising the skin, the patient was administered 0.5 mg/kg of ICG intravenously. The following slide is going to demonstrate the video images that were obtained less than 20 seconds post-injection. So again, here are the original APF margins drawn. And this upcoming view that you will see is what's called the color segmented fluorescent mode. And this is used to image different levels of ICG uptake, demonstrating higher levels of perfusion. So on the right, you can see this bar that where red is going to be higher concentrations of ICG. And then in this view here, what's called the SPY fluorescence mode, this is going to clearly show the actual caudal superficial epigastric artery as it exits the caudal portion of the inguinal canal. Here in this video, you can see the surgeon tracing the vessel using a sterile marker to the most cranial extent of the visible vessel. And then after we see the surgeon tracing this vessel, we'll see the altered flap margins that the surgeon developed based on these images here. So again, based on the NIRF-A ICG videos and images, the surgeon elected to adjust their margins. specifically the medial margin of the flap, which is indicated by those top dotted lines. So they adjusted it approximately 1 centimeter. And then they also ensured that their lateral incision did not overlap with the increased fluorescence, which was shown in that color segmented fluorescence view in the top right. And that's demonstrated by the dotted lines in the bottom of that left image there. The flap was elevated, transposed, and sutured routinely to the wound bed. And then a Jackson-Pratt drain was also placed and the wound was reimaged after an additional dose of ICG was given. And that's shown in the top right and bottom right images there. Postoperatively, the patient was maintained on methadone as needed, gabapentin, and meloxicam for pain control. Wound culture revealed a multi-drug resistant Staphylococcus pseudointermedius, and the patient's antibiotics were changed to amikacin. Renal values were monitored with serial blood gases and urinalyses, and 3 days postoperatively, the drain was removed and the patient was discharged. The patient returned 12 days postoperatively for suture removal. Her renal values and urinalysis were unremarkable. All sutures are removed without complication, and the flap had 100% survival, as demonstrated by the images on the right. The second case was a 10-year-old male-neutered mixed-breed dog that was presented for evaluation of a non-healing wound over the left lateral hip. The patient had a 3-year history of diabetes mellitus. When the wound, suspected to be acute moist dermatitis, was first noticed, it was non-responsive to topical therapy. 1 month later, the wound became necrotic and initial wound resection was performed. The incision failed to heal properly, and culture at the time revealed a methicillin-resistant Staphylococcus aureus. Despite appropriate antibiotic therapy, the wound failed to heal, and a repeat culture 2 months postoperatively showed a methicillin-resistant Staphylococcus pseudointermedius, which is depicted on the right of the slide. On presentation, 4 months post-initial wound resection, there was a 5 by 2 centimeter alopecia and erythematous wound on the proximal left lateral pelvic limb with associated necrotic skin. Surgical excision was performed with 2 centimeter margins around the wound. Samples were collected and submitted for histopathology and culture, and the distal 2/3 of the incision was closed primarily, while the proximal 1/3 was left open and a tie-over bandage was placed. Daily bandage changes were performed, and closure of the proximal aspect of the wound occurred 3 days postoperatively using a deep circumflex iliac APF, specifically utilizing the dorsal branch. Again, reference lines defined by anatomic landmarks were marked on the patient, and the patient was then administered a total of 3 mg of ICG, and the deep circumflex iliac VFP was visualized. The following slides will demonstrate the video images obtained again less than 20 seconds post-injection. Here again are those cranial dorsal borders drawn according to anatomic landmarks. And in this clip, you can actually observe the surgeon tracing the deep circumflex iliac artery VFP dorsally. In the next video coming up, the surgeon is going to demonstrate the 2 VFP of the deep circumflex iliac as it actually leaves the lateral abdominal wall cranioventral to the ilial wing right there. So based on the Nerfe ICG videos and images, the surgeon elected to adjust the cranial border to the above orange margin, which was 2 centimeters caudal to the original line. Postoperatively, the patient was maintained on methadone as needed, gabapentin, as well as carprofen for pain control. He was continued on chloramphenicol and his insulin therapy. The patient was discharged the following evening with drain removal planned for 3 days postoperatively. However, the patient removed his drain prior to his first reevaluation, and a less than 3 millimeter opening developed on the most distal third of the incision. Additionally, a large seroma was present beneath the incision, and conservative management of the seroma and opening was recommended and overall was uneventful. Diagnostics are here listed on the right and overall primarily showed inflammation. Sutures were removed at 18 days postoperatively with 100% flap survival and complete resolution of the seroma. No complications with the flap have been noted since the last recheck. Unfortunately, we don't have images of the flap from the suture removal, but here are images of the flap from day 6 and 10, and it looks fantastic. So these cases demonstrate that Nerfe with ICG is useful for visualizing the direct cutaneous arteries and associated angiosomes of APF development. In both instances, visualization occurred in under 20 seconds post-ICG bolus. This technique can guide surgeons in APF margin planning by facilitating real-time intraoperative visualization of the vessel of interest. The technology is easy to use and interpret in the OR, and no complications secondary to ICG administration occurred in either case. Overall, these cases demonstrate that using Nerfe with ICG facilitated a successful postoperative outcome with 100% flap survival, suggesting that Nerfe with ICG may be an effective method for improving APF planning and development, resulting in higher flap survival rates. Currently, there is a prospective clinical study in progress as a part of my master's research, and the objectives of this project are listed on the left. The video on the right depicts a video clip from our study. And what that first image that you should have seen here depicts is the borders of the omocervical cranially and thoracodorsal APFs caudally. This is indicative of the spine of the scapula right there. And as you watch this video, you can actually see the VFPs of these flaps develop post-ICG bolus. We believe that by improving our identification of these vessels, we will improve the overall success rate of APFs by ensuring the most accurate and adequate sources of perfusion. Ultimately, we believe this research will improve the standard of care for patients requiring APFs. I'd like to thank the Society of Veterinary Soft Tissue Surgeons for allowing me to share these cases with everyone today. I'd also like to thank my mentor, Dr. Fox Alvarez, as well as the other members of my master's committee listed on the right. And finally, I'd like to thank everyone on the UF Small Animal Surgery Service for their help and guidance. At this time, I'm happy to take any questions. Thank you for your time.
Just to recap what we already know about soft tissue sarcomas. Reports state that they account for 8 to 15% of all subcutaneous and cutaneous tumours in dogs and are often found in older, medium to large breed dogs. Low-grade soft tissue sarcomas are reported to have a low propensity for metastasis and are more likely to recur at the site of excision. The rate of recurrence is variable depending on grade and aggressiveness of excision. However, the majority of dogs die from unrelated causes. The reported median survival time estimated in studies by Chase and Kuntz varies from 1,013 to 1,416 days. There has been little new data in the literature on soft tissue sarcomas over the past 10 years. While there have been previous reports on recurrence of soft tissue sarcomas according to histologic grades and varying surgical margins achieved, there have been no reports on the long-term outcome of large soft tissue sarcomas. Thus, our objective was to evaluate the long-term outcome for dogs following excision of large, low-grade soft tissue sarcomas. In order to seek data to fill this gap in knowledge, we performed a historical cohort study. Medical records of dogs which presented to the Animal Hospital Murdoch for mass excision between 2009 and 2021 were reviewed. Dogs were included in the study if they were identified to have excision of a primary soft tissue sarcoma that was 5 centimeters or more in one plane and was confirmed to be grade 1 or 2 on histologic analysis. Information from the medical records was obtained to review the signalment, tumour location, tumour size, pre-surgical diagnostics of fine needle aspiration or incisional biopsy, tumour imaging, surgical findings, histologic diagnosis following excision, and short-term outcome. Long-term follow-up was obtained for dogs via telephone, email, or consultation with the owner. The questions asked at long-term follow-up related to the dog's overall function, whether there was any owner or veterinarian noted recurrence at the surgical site, and whether the dog was still alive. For dogs that had died or had been euthanized at the time of owner contact, the date and reason were recorded. Follow-up data was used to estimate the disease-free interval, defined as the time from surgical excision to observed recurrence at the surgical site, and to estimate the survival time, which we defined as the time from surgical excision to euthanasia or death due to any cause. Observations for dogs without recurrence or dogs that were still alive were censored for analysis. There were 39 dogs that fit the inclusion criteria for the study, including 21 females and 18 males. Dogs ranged in age from 6 to 15 years and weighed from 9 to 60 kilos. There were 20 breeds represented overall, with Labrador and Golden Retrievers and Staffordshire Bull Terriers most frequent. Preoperative diagnostic evaluation included fine needle aspiration, incisional biopsy, or both, as well as CT imaging. The typical CT appearance, as seen in the image on the right, was of a homogeneous soft tissue attenuating mass with well-defined margins and no invasion of underlying muscle planes. These characteristics are seen in the image on the right and are consistent with lower-grade soft tissue sarcomas. All dogs in the study that underwent CT imaging had no evidence of local or distant metastasis. Here is a case example of one of the dogs that underwent CT imaging. Dougie was a 9-year-old male-neutered Rhodesian Ridgeback who presented with a large, slow-growing mass. He had previously had a fine needle aspirate performed that was indicative of a soft tissue sarcoma. CT imaging performed on Dougie revealed a large soft tissue attenuating mass in the subcutaneous tissues of the caudal thorax. The mass was well defined without invasion into the underlying muscles, and there was no evidence of metastasis. Thus, the CT findings supported a likelihood of low-grade soft tissue sarcoma. The histologic analysis for Dougie's mass was a grade 1 soft tissue sarcoma. Another case example is Momo, who was an 8-year-old female spayed Siberian Husky cross, presenting for a large soft tissue mass at the cranial aspect of her thorax. Her CT showed a soft tissue attenuating mass with well-defined margins located with close proximity to the underlying superficial pectoral muscles. There was no evidence of muscular invasion and no metastasis present. Momo's histologic report returned a grade 2 soft tissue sarcoma. The tumour dimensions of all dogs were recorded from measurements taken preoperatively, at surgery, from images reviewed, or from the pathology report. Tumours had a median longest dimension of 8 centimetres, ranging from 5 to 20 centimetres. Majority of tumours were located on the hind limbs and the thorax, with 9 tumours on the thigh and 8 on the thorax. These findings are consistent with reported anatomic locations for soft tissue sarcomas described in the literature. All tumours were resected with cutaneous margins that varied from wide to narrow depending on location. A deep fascial plane was resected in all locations where this was possible. Surgery was performed by a board-certified specialist in all cases. All sites were closed primarily with either direct apposition in 22 dogs or reconstruction using a local or axial pattern flap in 17 dogs. And various skin flaps were used, with an inguinal flank fold flap most commonly employed. A closed suction drain was also placed in 23 dogs. Of the 39 tumours excised, 26 were confirmed as low-grade soft tissue sarcomas and 13 were considered intermediate grade. There were several tumour types, with the majority classified as undifferentiated soft tissue sarcomas, with 6 peripheral nerve sheath tumours and 6 perivascular wall tumours diagnosed. For all soft tissue sarcomas, the histologic margins were free from neoplastic cells. Long-term follow-up ranged from 60 to 3,586 days, at a median of 1,064 days. Most owners reported that their dog had recovered well with good functional outcomes. There were only 2 reports of local recurrence by owners, neither of which were confirmed by a veterinarian. Both of these dogs had low-grade soft tissue sarcomas with reported recurrence at 549 and 1,053 days. Kaplan-Meier estimation of the disease-free interval was a mean of 1,023 days, with the median disease-free interval unestimable because the function never crossed the 50th percentile. A presumed 5% recurrence rate from the reported 2 out of 39 cases is favourable compared to previous reports on soft tissue sarcomas. Kaplan-Meier estimation of survival showed a median of 1,022 days. Of the 39 dogs in the cohort, only one owner reported that their dog was euthanized because of the presumed recurrence of soft tissue sarcoma. All other deaths were due to unrelated causes. Thus, the dogs in the studies with a median age of 10 years lived on average another 3 years following excision. These results are again favourable and support previous statements that dogs usually die from causes unrelated to soft tissue sarcoma. In conclusion, our experience would show that despite these tumours being large, where they are in a location that is amenable to primary closure, a narrow margin excision of a low-grade soft tissue sarcoma can have a favourable outcome. Confidence in the ability to completely excise the lesion comes from preoperative diagnosis, for which CT offers the most information around local behaviour of the mass and the feasibility of resection, as well as confirmation of disease stage. Furthermore, preoperative incisional biopsy, particularly when the CT findings are suggestive of more invasive behaviour that is uncharacteristic of low-grade soft tissue sarcomas, would be highly encouraged. Initial hesitation, simply based on the size of the mass, should not be used as a deterrent for intervention. Thank you.
Liposomal bupivacaine injectable suspension, or Nucita, is currently labeled for use as a one-time local infusion in dogs undergoing surgery to address cranial cruciate ligament disease. Most studies to this point have been either laboratory safety studies in dogs or rabbits, or on the clinical side of things, evaluating the analgesic efficacy of liposomal bupivacaine use. However, up until now, there have been no previous reports looking specifically at incisional complications. So again, probably a review for most of those in this audience, but the technique for instilling liposomal bupivacaine involves the sliding needle technique at time of incisional closure, and it is instilled in the multiple layers of the incision during the time of closure, so fascia and subcutaneous. And on the molecular level, the drug involves an aqueous core with the bupivacaine encased in this kind of liposome bleb that will allow slow release of the anesthetic over time, and it's labeled for about 72 hours. So to emphasize kind of why we wanted to look at liposomal bupivacaine, we are all familiar with the benefits of local anesthetic utilization in small animal surgery. For one thing, kind of using it as a component of multimodal analgesia allows us to minimize our opioid use, both for some of the unwanted side effects, dysphoria, nausea, things like that, particularly in some of our brachycephalic animals. And on the kind of logistic side of things, oftentimes these days with restrictions surrounding opioid use, we may not always have access to them. And although NSAIDs are a great option for postoperative pain in many patients, some animals are not a candidate for their use. So all goes to say that being able to utilize local anesthetics in our pain management protocols can go a long way for effective postoperative pain management in our patients. So the objective of our study here was to look at the incidence and severity of short-term incisional complications we observed when liposomal bupivacaine was used in dogs undergoing a range of various surgical procedures. And we had a few different hypotheses that we were looking at within our study, and we broke up our surgeries in a few different ways and hypothesized that we would not observe a statistically significant difference in our incidence of short-term incisional complications between these different groupings of our surgeries. So we first grouped them in terms of surgical wound classification, so clean, contaminated, and contaminated surgeries. We then looked at them by orthopedic versus soft tissue. And then within our orthopedic group, we wanted to look at labeled use, which at this time is surgery to address cranial cruciate ligament disease, versus off-labeled use, which was orthopedic surgeries that were not addressing cranial cruciate ligament disease. So essentially any other type of orthopedic surgery. This was a retrospective study. We went back through records for 218 client-owned dogs. In terms of how our grouping shaped out, we had 95 orthopedic cases. 72 of those were labeled use for cruciate surgery, and the remaining 23 were other types of cruciate surgery, not treating cranial cruciate ligament disease. And we had 123 soft tissue cases. And splitting those up by surgical wound classification, 192 were clean, 13 were clean contaminated, and another 13 were contaminated. So this chart here essentially just shows you which types of surgeries fell within which categories of surgical wound classification. So the vast majority were clean procedures, so all of our orthopedics, and you can see the various soft tissue surgeries we had included there. The clean contaminated and contaminated groups were much smaller. So for clean contaminated, we had laparotomy with incision into the gastrointestinal or urogenital tract and total ear canal ablation. And for contaminated, we had wound repair, anal or perianal masses, anal sacculectomy, episiotomy, and in one case, we had a laparotomy with a pancreatic abscess, so that was included in the contaminated group. Materials and methods, as I mentioned, this was a retrospective study, so we were going back through medical records for patients who had received liposomal bupivacaine at the time of incisional closure. And since we were looking at short-term complications, we set the cutoff for the development of a complication at 20 days post-operatively. And in terms of what was deemed a complication, it was essentially any type of abnormality with the incision documented up to that 20-day point. So we had a range of things we noted, including bruising, dehiscence, dermatitis, discharge from the incision, edema or ephema surrounding the incision, surgical site infection, second intention healing, or seroma. Another level of what we looked at in our incisional complications was how severe the complication was. This was adapted from a study that was done by Field et al. Out of JSAP in 2015, and the severity was determined based on which type of treatment was indicated to address the particular complication. So a complication severity score of 1 would be something where no treatment or only topical treatment was required, such as maybe a topical antiseptic or warm compressing. So by and large, those are things like incisional erythema or something pretty minor. Complication severity score of 2 would be a case in which systemic antimicrobials were required. So in most cases, a surgical site infection. And a complication severity score of 3 would be something where revision surgery would be indicated. So in most cases, it was a complete dehiscence or a severe surgical site infection. In terms of our results, overall, our complication rate was just under 20%, which when we broke it down into our complication severity scores, the vast majority, about 63%, were a complication severity score of 1. So again, something where either no treatment or only topical treatment was indicated. About a quarter of them did require systemic antibiotics, and about 12% of them, of the complications, had to go forward with revision surgery. So that's kind of just splitting up the cases overall and looking at them by surgical wound classification. About 19% of the clean procedures had a complication, 23% of the clean contaminated, and about 31% of the contaminated surgeries had a short-term incisional complication. And finally, looking at them by soft tissue versus orthopedic surgery, we saw short-term incisional complications in 26% of our soft tissue cases and 12% of our orthopedic cases. Splitting those up further into cruciate surgery versus non-cruciate surgery, we were at about 14% for cruciate surgery and about 4% for non-cruciate surgery. This is just a summary chart we had kind of looking at our 3 hypotheses and different numeric patient variables. So essentially the only significant difference in the incidence of short-term incisional complications was seen with soft tissue over orthopedic cases. Going through the different surgical wound classifications, we did not see a significant difference in the incidence of complications, nor within orthopedic surgery for CCL surgery versus non-CCL surgery. Looking at the bottom of the chart with some of the patient variables, we did not see the difference in complications based on patient age, weight, or the dose of liposomal bupivacaine administered. And those were not specifically evaluated by our hypotheses, but just some data we felt relevant to include after we went through and got the statistics. Limitations of our study, obviously being a retrospective study, we were dependent on the medical records being complete, going back through and documenting when we saw a comment that there was something abnormal with the incision and how that was treated. So as with any retrospective study, there are inherent limitations going through things in that fashion. Another big limitation was we did not have a control group here. And, in the future with a prospective study, having a placebo group where just saline is administered or a non-liposomal local anesthetic like ropivacaine would be a useful control group to compare versus cases in which liposomal bupivacaine was administered. Another limitation we ended up having was splitting up our soft tissue cases. As you saw in our chart several slides back, we had a wide variety of different soft tissue cases, and they were difficult to break up by body system while still maintaining sufficient sample size for power analysis. And there was wide variability in the types of complexity of soft tissue surgery we were doing. For example, a neuter versus a complex mass removal would involve differences in, tension on the closure and things like that. And we simply couldn't standardize for all of those different variables. But moving forward, prospective study might be able to better delineate some of those different complexities and better standardize those types of factors. Another thing that we didn't specifically define were comorbidities. For example, certain patients in our population were documented to have dermatologic disease and therefore potentially higher chance of developing an incisional-related complication, as well as endocrinopathy, things like diabetes and Cushing's, where impaired wound healing may play a role in the development of complications, were not specifically evaluated in our study, and again, probably better suited for evaluation by a prospective study where those variables can be more standardized. So conclusions we can take away from our study, we did document that liposomal bupivacaine use appears safe for off-label use in orthopedic procedures, in addition to its currently labeled use for surgery to address cranial cruciate ligament disease. Although we did not note a difference in complications across the different types of surgical wound classification, it's important to note that we had pretty small sample sizes for the clean, contaminated, and contaminated groups, about, again, 13 cases in each of those categories. So that certainly could limit the statistical power of that finding. We did note a significantly increased incidence of incisional complications in soft tissue cases. So until we can better define that, we should perhaps exercise more caution or discretion with using liposomal bupivacaine in those cases. And as I mentioned on the limitations slide, we don't really know to which degree this may have been due to liposomal bupivacaine itself versus inherent risk factors with the patient and the type of surgical procedure performed. And another takeaway that I think is important is when we did observe a complication, they're more likely to be minor. Again, 63% of them were indicated to have either no treatment or just a topical treatment only, so minimal morbidity and cost for the patient and client. And in some cases, we don't know if some of these complications may have been incidental, coming in for suture removal and just documenting that there was some erythema may or may not be clinically relevant in the grand scheme of things. I'd like to acknowledge Dr. Davis, who's my mentor and advisor and co-author on this study, as well as our other co-authors, Dr. Bergman, and then we had Talon McKee and Kara Jourdan were a big part of getting this study together. Some references here. If you have specific questions on these, feel free to reach out to me since I know we're flipping through this pretty quickly. And I'll take any questions anyone may have, and thanks again for attending my talk.
Burns and traumatic wounds are relatively common in the veterinary practice. They can arise from numerous causes. Early and aggressive treatment of these wounds, as well as long-term management, is critical for a successful outcome. Current standard of care for wounds in companion animals includes cleaning and debridement, maintaining a moist wound environment, prevention of infection, and compression of the wound. Depending on the location and severity of the wounds, primary closure can be difficult or impossible. However, leaving the wound to heal by second intention can be a lengthy process and risks patients developing resistant infections as well as large areas of contracture and scarring. A recent study showed that fish skin xenografts allowed for faster healing, no risk of autoimmune reactivity, and since there's little risk of communicable disease, it's able to be gently processed, allowing more healing factors to be preserved. In this case series, we looked at specifically the Kerecis omega-3 product. This acellular fish skin graft is generally used to treat complex or chronic wounds in people, and it has become available for treatment of complicated wounds in animals. The fish skin is obtained from North Atlantic cod, and it undergoes gentle processing, therefore maintaining omega-3 fatty acids, collagen, elastin, laminins, lipids, fibrins, proteoglycans, and glycoaminoglycans. The fish skin grafts are homologous to mammalian skin and have shown to speed wound healing, serve as an effective antimicrobial barrier, and provide anti-inflammatory properties. While it has been extensively studied in human medicine, there's currently no formal studies evaluating its use in veterinary medicine. Cod skin grafts are often confused with tilapia biobandages, but they are not the same thing. Both protect from burns, but the cod skin actually integrates into the wound bed and acts as a scaffolding for the recipient's cells, as well as providing many more healing factors. The purpose of this study was to report the clinical outcomes of using acellular fish skin xenografts for the management of complex canine and feline wounds. This is the first case series reporting the use of commercially available acellular fish skin xenografts in veterinary patients. Veterinary hospitals with a history of purchasing a fish skin xenograft from Kerecis were contacted to contribute cases to this study. Patients were included if they had a wound that was not able to be managed with primary closure and had a fish skin graft used in wound management. There was no exclusion regarding signalment of the patients or the health status. All cases had owner consent for use of the fish skin xenograft, and data acquired from medical records was analyzed. The primary outcome of this study was the proportion of patients who achieved complete wound closure. Additional outcomes included time to closure, number of graft applications, and number of product-related adverse events. After the wound is debrided and lavaged, a healthy granulation bed should be present. First, the fish skin xenograft is removed from the pouch using aseptic technique. The graft is rehydrated with room temperature saline for 1 minute, and then it is cut to fit the size of the wound. The graft is applied directly to the wound with the scale pattern up, and it's compressed until bleeding stops. The graft is fixed into place using skin sutures or staples along the margin, and the graft is covered with a dressing to ensure optimal exudate management and wrapped as needed to secure and protect the dressing. It's important that the graft remains moist and in close contact with the wound. The graft typically integrates within 7 to 10 days, depending on the size and location of the wound as well as the rate of healing. And as you can see in the middle picture, if you have a large wound bed and the fish skin grafts don't go to that size, you can use some sutures that are fastly dissolving, such as monocryl, to tack them into the granulation bed. Here we have a breakdown of the different signalment as well as the wound causes and signs in this study. So there were 10 different breeds of dogs in the study, and there was a wide range in ages. And then we had a wide range in age of cats as well. 5 of the cases were trauma-related, 3 were burns, several were ulcerated hygromas and failed skin flaps, and the wounds ranged from 1 centimeter by 2 centimeters to greater than 40% of the body. In dogs, the number of fish skin graft applications ranged from 1 to 4. The time between each application ranged from 4 days to 21 days. 12 out of the 13 wounds closed by second intention healing following the first fish skin application between 26 and 145 days. In cats, 1 to 2 fish skin grafts were used, and 3 out of 4 wounds healed completely by second intention. 1 wound in each dog and cat group did not heal. The dog case was an elbow hygroma, and amputation of the limb was elected. The cat case didn't heal after 2 applications, and amputation was elected. There were no adverse events attributed to the use of the fish skin grafts. Here is one of the cases. This is a 3-year-old female spayed Dalmatian, and she presented following exposure to a brush fire. Approximately 40% of her body had 3rd-degree burns or singed hair concentrated over the left lateral trunk and left hind limb. This patient required 2 graft applications. Wound closure was achieved after 127 days, and this was after her first application was just applied. And then this was 127 days later, and you can see there's nice epithelialization and minimal wound contracture present. The main area with some contracture was in her left flank area, but she still had good range of motion in that leg and could use that leg well. This is another case. This is a 2-year-old spayed female golden doodle presenting for a degloving injury after being hit by a vehicle. The patient had a wound that extended from her distal scapula to her carpus on her left front limb. She needed a total of 4 fish skin graft applications, and she also received punched autografts to aid in continued epithelialization. She had wound closure after 168 days, and this was her after her first application of the fish skin grafts. And this was 168 days after, and you can see she had minimal wound contracture, and she was able to use the limb with rehab exercises. She did have some intermittent edema in the paw during treatment, and this was likely due to compromised vascular and lymphatic supply sustained from her original injury. This improved once she started using her limb more regularly. Here you can see another canine patient with a wound on the proximal limb. This first picture is after a graft application. The second picture is after the first graft integrated. And in this third picture, you can see after the second graft integrated, and there is a nearly healed wound bed with really good epithelialization and minimum contracture of the wound. This is a 4-year-old spayed female domestic short-hair cat presented for evaluation after a traumatic wound is suspected to be a dog attack. This first photo shows the wound just prior to application of the fish skin grafts. This is 10 days after the fish skin graft was placed. And then this is after the wound was completely healed by second intention in 12 weeks. And this cat only needed 1 application of the grafts. It's difficult to extrapolate from this data if applications were limited to 1 graft due to a significant improvement in the wound bed, financial limitations, patient owner compliance, or lack of experience using the product. And then also with various wound sizes, times to closure, it is difficult to predict the effect that multiple graft applications or a decreased time interval between graft applications would have on the healing rates. This is the first case series reporting clinical outcomes of the fish skin grafts for the management of canine and feline wounds. The use of intact fish skin grafts facilitated the complete healing and minimal contracture of most wounds. The future directions are that it's beneficial in management in difficult to heal wounds. There's no adverse effects of using the grafts. There's no required special training, instruments, or bandage materials, so general practice and specialty practices both could use this product. And in the future, a prospective randomized clinical trial with more standardized protocol will be needed to evaluate clinical effectiveness further. Thank you, and I will take any questions that you have.
Limbs are commonly amputated for a variety of reasons, including trauma, neoplasia, and developmental deformities. Previous literature has demonstrated excellent functional outcomes in patients after limb amputations, including a quick return to ambulation and low complication rates. Complications do occur, including surgical dehiscence, infection, phantom limb pain, and poor return to mobility. Poor candidates for amputation have historically included patients with comorbidities such as obesity, orthopedic disease in other limbs, or neurologic diseases. Studies have also shown that the altered biomechanics of ambulation after amputation, including changes to ground reaction force and contact times of the remaining limbs, may predispose the remaining joints to accelerated degeneration. Multiple limb amputations are rarely considered a viable treatment option in veterinary medicine, despite the fact that they're regularly performed in humans. Multiple limbs are amputated in humans for a variety of indications, including trauma, vascular disease, and congenital abnormalities. The obvious reason for this difference between veterinary and human medicine are the vast variety of prosthetic options available to people and the use of wheelchairs. Humans commonly undergo prolonged extensive inpatient and outpatient therapy after multiple limb amputations. Currently, there is no published data on multiple limb amputations in veterinary medicine. The objective of this study was to report the indications for, complications associated with, and the surgical outcomes of dogs and cats that were treated with multiple limb amputations. Our study included 14 dogs and 4 cats. The Veterinary Society of Surgical Oncology and the Society of Veterinary Soft Tissue Surgery listservs were queried, asking surgeons to contribute any cases of multiple limb amputations they had performed. Surgeons were asked to contribute cases regardless of outcome. Medical records were reviewed, and all animals with at least short-term follow-up information were included. Data collected included signalment, indications for amputation, surgical information, hospitalization time, comorbidities, complications, and revision surgeries. Staged amputations were defined as those in which each limb was amputated during its own surgical and anesthetic event. The perioperative follow-up period was defined as the time from surgical amputation until patient discharge. The short-term follow-up was defined as the period from discharge to the first recheck, or 14 days, and long-term follow-up was defined as the time after first recheck, or 14 days. The surgeons were also asked to obtain a satisfaction score from the owners, which was on a 5-point scale ranging from 1, strongly dissatisfied, to 5, strongly satisfied or excellent satisfaction. The 14 dogs in the study included 4 female spayed, 4 male neutered, 3 female intact, and 3 male intact dogs. 7 were mixed breed dogs, and the remainder were one each of Bull Terrier, Pug, Miniature Poodle, Belgian Sheepdog, Doberman, Tree Walker Coonhound, and Pit Bull. Mean weight of dogs was 14.6 kilograms, ranging 1.9 to 30 kilograms. Mean age of dogs was 3.7 years, ranging 0.2 to 8.3 years. Of the 4 cats, 2 were female spayed, 1 was male neutered, and 1 was female intact. 3 of the cats were domestic shorthairs, and there was 1 ragdoll. Mean weight of cats was 3.8 kilograms, ranging 3.1 to 4.1 kilograms, and mean age of cats was 1.4 years, ranging 1 to 2.5 years. Of the 18 cases, 11 had both amputations performed during the same surgical event, or unstaged. The remaining 7 cases were characterized as staged procedures. Of these 7 staged cases, 6 had 1 limb removed at each surgical event. The other had bilateral partial limb amputations at the first surgical event and full amputation of the remaining portions of those limbs at a second event. Of the 12 cases of bilateral pelvic limb amputations, 10 were dogs and 2 were cats. Of the 4 patients with bilateral thoracic limb amputations, 3 were dogs and 1 was a cat. The remaining 2 patients, 1 dog and 1 cat, had amputations of 1 thoracic and 1 pelvic limb on contralateral sides. The predominant indication for multiple limb amputation was trauma, accounting for 66.7% of multiple limb amputations. Other indications included neoplasia, neurologic disease, orthopedic complications, ischemic vascular disease, and chronic limb trauma due to paralysis. Regarding the bilateral thoracic limb amputees, this group consisted of 3 dogs and 1 cat. 2 of the 4 bilateral amputations were staged, and 2 were unstaged. 2 of 4 were partial limb amputations, and 2 of 4 were full limb scapulothoracic disarticulations. Comorbidities were reported in 2 dogs. One was an 8-year-old female spayed pug with reported Cushing's disease, hip dysplasia, and back pain, and the other was a 1.8-year-old female intact miniature poodle with bilateral medial patellar luxation. The overall complication rate in this group was 50%, with major complications reported in 2 of the 4 animals, one of which was the 8-year-old pug previously mentioned who failed to regain ambulation status. The other patient was the 1 cat who underwent surgery for skin grafting to facilitate surgical site healing at both stumps after partial limb amputation. The largest of the 3 groups, those that underwent bilateral pelvic limb amputations, consisted of 10 dogs and 2 cats. 4 of these 12 were staged amputations, and 8 were unstaged. 7 of 12 were partial limb amputations, and 5 were full limb coxofemoral disarticulations. Comorbidities were reported in 6 of 12 animals. These included chronic T12 vertebral body fracture, chronic UTI, urinary and fecal incontinence, paraplegia, soft tissue shoulder pain, tail sores, and ischemic vascular injury of unidentified etiology. Overall complication rate was 25%, 2 of which were minor complications, and 1 of which was major. All 3 of these animals also had reported comorbidities. The first minor complication was in a 0.7-year-old female spayed Belgian sheepdog with a chronic T12 vertebral body fracture and chronic UTIs, whose surgical site underwent dehiscence and infection. This was managed conservatively. The second minor complication was in a 1-year-old male castrated German Shepherd with comorbidities of urinary and fecal incontinence. Incomplete healing of the surgical incision after the second limb amputation was reported at the first recheck at 14 days and resolved without any intervention. The one major complication was reported in a 2.5-year-old male castrated ragdoll cat with reported ischemic injury of unknown etiology. This cat's partial bilateral pelvic limb amputation stumps suffered from infection and dehiscence and were treated surgically with stump removal, resulting in full limb coxofemoral disarticulation. The final group, those that underwent amputation of one pelvic and one contralateral thoracic limb, consisted of one dog and one cat. One was a staged procedure and one was unstaged. Both animals' procedures were full limb amputations. One animal, a 1-year-old female intact domestic short-hair cat, reported anemia prior to amputation. No complications in any of the follow-up periods or revision surgeries were reported in this group. Looking at complications specifically, 5 of the 18 animals in the study reported one or more complications over the short and long-term follow-up periods. These included 2 cats and 3 dogs. Of these 5 complications, 2 were considered minor complications with a minor complication rate of 11.1%, and 3 were considered major with a major complication rate of 16.7%. 4 of these 5 animals had reported comorbidities prior to amputation, and 4 of 5 had staged amputations. No perioperative complications were reported. 4 patients had complications in the short term. 2 patients had minor complications, and 2 patients had major complications. And in the long-term follow-up period, 2 patients had major complications, one of which was a continuation from the short-term time frame. Regarding owner satisfaction, 14 of 18 owners reported a score of very satisfied or excellent. 3 of 18 were mildly satisfied, and 1 owner was strongly dissatisfied. The owner who reported a strongly dissatisfied score owned the 8-year-old pug with comorbidities who underwent bilateral thoracic limb amputation to treat bilateral humeral ulnar fracture, non-union, and osteomyelitis. The dog's refusal to use his four-limb wheelchair continued from the short-term into the long-term follow-up period and was the eventual cause of euthanasia, as the owner felt the patient's quality of life was poor. Of the 5 cases with reported complications, 4 owners still reported scores of very satisfied. We were pleased to see that the majority of the animals in our study, 78%, achieved an excellent owner satisfaction score. 94% of owners reported being either very satisfied or mildly satisfied. This finding may be a product of response bias or provides insight into the communication of expected results that the surgeons had with these owners. The owners of the patients that our corresponding author was involved in had extensive discussions about possible complications and outcomes. Other interesting findings from the study is that 4 or 5 patients that reported complications during the follow-up period underwent staged amputations, and bilateral thoracic limb amputations had a higher proportion of complications. The majority of these complications included incisional issues, which could be expected with these procedures, as it is not easy to protect these incisions during the healing process, as there is not a normal limb present. All but 1 of the complications went on to resolve with either minor or major interventions. It also seems intuitive that bilateral forelimb amputations would have more difficulty adapting to ambulation, as we know the majority of weight is usually carried in the front. There are many factors to consider, however, such as age, weight, and comorbidities, and larger studies would have to be performed to tease out the true statistical significance between the groups. As with all studies, there were limitations. While we were happily surprised to find 18 patients for this study, there were small numbers of included cats, and 2 of the groups, bilateral thoracic limb amputees and mixed limb amputees. The retrospective nature of this study allows for potential loss of data, variety in surgical techniques, and postoperative management protocols. As mentioned earlier, response bias may have affected reported owner satisfaction scores, as clients generally want to feel good about proceeding with procedures, and this procedure in particular could seem socially distasteful by the community at large. Lastly, selection bias may have also played a role if only surgeons with positive outcomes reported to our survey. In conclusion, the authors believe that patients suffering from multiple limb injuries or disease, especially in the pelvic limbs, can have an excellent outcome with simultaneous amputations. In cases of financial constraint or severe limb disfigurement, multiple limb amputations may be a viable alternative to endo and exoprostheses in achieving an acceptable quality of life without increased complication risk. More research is required in various aspects of multiple limb amputations, including possible investigations into comorbidities that may serve as negative predictors for successful ambulation, as well as other factors such as species, pelvic versus thoracic limbs, and indications for amputation that may predispose to poor outcomes. Thank you to all of the contributing authors to the study, especially Dr. Buat, who helped guide me through this process. Thank you to the surgeons of the VSSO and Soft Tissue Society who contributed their cases, and to the Soft Tissue Society for allowing me to present today. These are 2 of our patients. And now I'm happy to take any questions.